We have discussed how to discover different ECGs, how to recognize them. I have told you for the atrial fibrillations, you look for this thing, the irregular rhythm. Okay, all the rhythm that you are seeing, they all are irregular. First of all, no R to R distance is same, and second thing, they all are in an irregular pattern. No regular pattern is there. Okay, so irregular rhythm. I have told the location of the origination of this AFib waves, and these are the pulmonary veins that contains the myocardial tissue. Okay, and I've also told you about the high risk of this embolization and the risk factors like the hypertension, the coronary artery disease, okay, and all these things. Then we have discussed the atrial flutter, and for that I have told you they have the regular rhythm. The R to R distance is always same, but they have no recognizable P waves. Okay, so whenever you see no recognizable P wave, you only think of two things. First is the AFib, and second is the A flutter. Okay, you have the sawtooth type waves in the atrial flutter. Okay, and I've told you the location of it, which is the cavo-tricuspid isthmus. Okay, and it is the area between the tricuspid valve and the crista terminalis. And I've told you about the crista terminalis, which is between the superior vena cava and the inferior vena cava. Okay, I've also told you the rate of ventricular contraction is totally dependent upon the AV node refractory period. The symptoms always will be like the palpitations or the chest pounding. Sometimes the patient also get the syncope, okay, because of the loss of cardiac output, right? These are just the symptoms, and for the symptoms, then you do the ECG, and on the ECG, you will get these tracings. Ventricular fibrillation, we have talked about. I've told you this is the most common cause of sudden cardiac death. All the waves are kind of irregular. No R to R waves would be seen. No recognizable, nothing. Okay. It could be seen in the Wolff-Parkinson-White syndrome. It could be seen in the Brugada syndrome. It could be seen in the Torsa de Pontes. It could be seen after the myocardial infarction. Okay. So whenever the STEM asks you about the cause of sudden cardiac death, you will always refer to the ventricular fibrillations. Then we have talked about the AV block. In the first case, you have the AV block, which is kind of asymptomatic condition. You just have a PR prolongation. The delay in the waves from the SA node to the ventricles would be prolonged, and that's why you get the PR prolongation. And the rhythm will be absolutely normal. Okay, just the PR prolongation is there. And whenever you do the exercise or the sympathetic stimulation is there, the sympathetic system will stimulate the AV node, and so that the symptoms could be improved. Okay, then comes the second degree block. In the second degree block, you have an irregular rhythm, but this irregular rhythm is in a regular fashion. Okay, so you have a regularly irregular rhythm, very important. In the Mobitz type 1, you have a AV node block, and that's why it could be improved with the sympathetic stimulation. Okay, you have an increasing PR prolongation as well as the increasing R to R distance, and the time will reach when the P wave would be there, but no QRS complex would be there, and the same cycle after that repeat again. Okay, for the Mobitz type 2, the PR distance is absolutely normal. You just have a R to R prolongation. Okay, then again a P wave without the QRS complex, and then the same cycle will be repeated. In the Mobitz type 2 block, you have a block after the AV node. Okay, most commonly in the His-Purkinje system. Okay, generally it could also be seen with the bundle branch block. In the bundle branch block, we will see the QRS widening, okay, and some changes in the different waves on different leads. Okay, then you have the third degree block, which is a complete AV block. Okay, in which the the pathway between the SA node and the AV node is kind of destroyed, so that the SA node and AV node are not in connection. So this SA node will generate the impulse, which would cause the atrial contraction. Okay, and now no impulse from the SA node could be reached to the ventricles, and that's why the AV node has to take over the function. The AV node will cause the ventricular contraction, but its own rate, which is around 40 beats per minute. Okay, so atrias, they are contracting at a 72 or 70 rates per minute, as you can see here, and then the ventricles, which are contracting because of the AV node and by their own rate, like a 40 beats per minute. Okay, So the rhythm is absolutely normal, regular. Both the atrial rhythm and the ventricular rhythm is normal, but they're contracting independent of each other. The SA node is causing the atrial contraction, and the AV node is causing the ventricular contraction. Okay, it could also be happen when the connection between the AV loss, when the connection between the AV node and the His Purkinje system is lost, and as a result, now the bundle of His will take over the function, and in that case, you will get the heart rate of like 20 beats per minute only. Okay, and I've told you how to count the heartbeats, which is to count the number of boxes, the 300, then 150, then 100, okay, then 75, and then 50, and so on, right? You need to remember this. If you count the box, you can get the heart rate. And when you get the heart rate around 40, it must be a block between the SA node and the AV node. When you get a heart rate of around 20, this must be a block between the AV node and this bundle of His. So you can easily recognize where the block is happening, right? And the most common disease, or one of a major cause of this third degree block, is the Lyme's disease. Okay, which is caused by the Borrelia burgdorferi, which has a tick. Can anyone remember the tick name?
Deer tick.
Deer tick, but what's the name of the tick?
Ixodes.
Ixodes.
Exactly. And what are the organisms this tick can harbor?
Borrelia burgdorferi.
One. And other two?
Francisella.
Francisella. No.
Is that the one?
Anaplasma second. If you remember anaplasma Q fever, right? Cows, cattle, patient will have a history. Then pneumonia and the involvement of liver along with pneumonia. Remember? Anaplasma. And the third one? Does anyone remember the third organism for the exodes tick? Babesia. Yeah, Babesia, right? So please remember three organisms: the Borrelia, Babesia, and Anaplasma. These three, they will always be harbored by the exodes tick. So that sometimes what happened that more than two organisms or more than one organism can cause a disease in a single patient, right? So you must remember that three organisms can be harbored by the exodes tick, and all of these patients, they will mostly from the Connecticut area, right? So yeah, that's a Lyme disease, and that's what I've written here. Okay, because the cell throughout the conduction system, they have the ability to generate the impulses. Okay, they all have the ability for the pacemakers, right? SA node, AV node, bundle of His, the Purkinje fibers, everyone. Okay, but SA node has the highest rate than any other cell, and that's why it will always take over the function. Okay, whenever the function is interrupted, okay, whenever the function is interrupted, all some other cells will have to take over the function, like the AV node, bundle of His, or any Purkinje fibers, and so on, right? So in case when the connection between the SA node and the AV node is lost, the AV node will take over the function, because after the SA node, this AV node has the highest rate of this impulse generation. Okay, and that's what exactly gonna happen in this third degree AV block. Okay, so any doubt on this page? If anyone has, please ask.
No.
Okay, so then you need to know about the atrial natriuretic factor and the B-type natriuretic factor, which is a brain natriuretic factor. Okay, both of them are released or secreted by the heart cells, the myocardial cells. Okay, the atrial natriuretic factor is this peptide is secreted by the atrial myocytes, and the B-type natriuretic this peptide is secreted by the ventricles, the myocytes in the ventricles. Okay, they work through the cyclic GMP, very important. And which G receptor is for the cyclic GMP?
Please repeat.
Cyclic GMP. How the generation of cyclic GMP can happen? Does it have any G receptor? G protein coupled receptor, cyclic GMP?
No.
Okay, please remember that only cyclic AMP has the G protein coupled receptor. Okay, that was a kind of a trick thing. Okay, no cyclic GMP has any G protein coupled receptor. Okay, very important. Okay, so they work through the cyclic GMP, and that's why they can cause the vasodilation. Very important. They can cause the vasodilation, and by causing the vasodilation, they can increase the renal blood flow. Okay, and when the renal blood flow is increased, the GFR is increased. When the GFR increased, what gonna happen? The loss of this with the filtration will be increased, and as a result, the sodium absorption will also be decreased. Okay, so they can cause this, and as a result, what's gonna happen? Natriuresis. That's why the name natriuretic peptides. They can cause the natriuresis, the loss of sodium. Okay, along with the water. Second thing they're gonna do, they will cause the constriction of the efferent arterioles. Very important. They cause the dilation of the afferent arterioles, and they cause the constriction of the efferent arterioles. So for everywhere inside the body, they will cause the vasodilation. Okay, but only in the efferent arterioles they will cause the vasoconstriction. Okay, so that the GFR could be further increased, the filtration fraction could be further increased, so you get more filtration of the urine and everything, and that's why and along with this thing, they can also decrease the sodium reabsorption. So more sodium and more water could be lost from the body. Okay, so they are very important in the cases of heart failure. Okay, and they also contribute in the aldosterone escape mechanism. Very important. You will study that later in the next chapter, I think. In the endocrine section, you will study about this aldosterone escape. Okay, so please remember that. Very important. They contribute in that. Then comes the brain type natriuretic peptides, and they are released from the ventricular myocytes. Similar to the ANPs, they have the function to the cyclic GMP. They will cause a vasodilation. They will cause the afferent arterial vasodilation and the efferent arterial vasoconstriction to increase the GFR and the filtration fraction. They also causes a sodium loss from the body. Okay, and whenever you have a heart failure, when these things are when these two peptides are actually released from the cardiomyocytes, whenever you have a very stretch in the cardiomyocytes, whenever you have an increased preload inside the heart, okay, whenever these myocytes actually stretched, okay, and due to the stretching, they will release these peptides. Okay, so whenever you have a fluid overload inside the heart, only then these ANP and the BNPs could be released from the myocytes. So these are the marker of your heart failure. Okay, whenever you have a heart failure, this BNP will rise from the ventricles, and you can easily detect the BNPs to check for the severity of the heart failure. Okay, very much important to know. The BNP blood test is used for the diagnosis of the heart failure. Okay, and their recombinant form, which is a nasiritide, very important to know. You have a drug known as the nasiritide, which is a recombinant form of the ANP and the BNP. Okay, very important to know that this thing also. And which enzyme can degrade these ANP BNP, if anyone remember?
Neprilysin.
That is a drug name, but the enzyme.
Sacubitril.
Sorry, yeah, it is an neprilysin and the drug is sacubitril. I'm sorry about that. Yeah, you're right. Okay, so you can also remember the difference between the neprilysin and the nasiritide. Do not confuse between the two. Okay, the nasiritide is a recombinant form of the BNP, and the neprilysin are their inhibitors. Okay, so you have a neprilysin inhibitor, which is a sacubitril. Okay, so very important again. Then you study about the baroreceptors and the chemoreceptors. Okay, so the baroreceptors and the chemoreceptors, they available in two places. Okay, actually there are two types, the central and the peripheral. For the peripheral areas, they are outside the brain, and for the central, they are inside the brain. Okay, so for the outside the brain, they have two locations. One is the carotid sinus, as you can see here, where the bifurcation of your carotid arteries occur into the external and the internal carotid artery. Okay, they have this location. Okay, and then they have the aortic baroreceptors, which is on the arc of aorta. Okay, so two locations. One is the bifurcation of the carotids, and second is the arc of aorta. Okay, for the bifurcation of the carotids, you have the carotid sinus baroreceptors and carotid body chemoreceptors. Okay, both of them, whenever they sense any change in chemical structure, like change in the oxygen level or the CO2 level, mostly the CO2 level, of course, and the change in the pressure inside the blood, or any volume inside the blood, they will send the impulses by the glossopharyngeal nerve. Very important. The impulses are sent through the glossopharyngeal nerve into the medulla. Okay. And from the medulla, the signals are transmitted back to the uh, system by the vagus nerve. Very important. The vagus nerve is the efferent nerve, and the glossopharyngeal nerve is the afferent nerve. Okay. Similarly, you have the aortic chemoreceptors and the aortic vasoreceptors. They send the impulse through the vagus nerve. Okay. And and these again, the impulses will be received by the vagus nerve. Okay. So for the aortic chemo and the vasoreceptors, with the afferent nerve is the vagus nerve, as well as the efferent nerve is the vagus nerve, because the vagus nerve will take part in the parasympathetic nervous system. Very important. Okay. So for the carotid bodies, you have the glossopharyngeal nerve. For the aortic bodies, you have the vagus nerve. Okay. They will send the impulses to the medulla, and from the medulla, yeah, inside the medulla center you have is the solitary nucleus. Very important. You have the solitary nucleus inside the medulla. You will study that later in the neurology section. Okay. So in the solitary nucleus, the impulse are reading. Okay. And the response is generated by the parasympathetic vagus nerve. Okay. And as you can see, the parasympathetic nervous system is only supplying the heart. As you can see in the diagram, the parasympathetic nervous supply is only supplying the heart, while the sympathetic nervous system is supplying both the blood vessels as well as the heart. Okay. So whenever you have a hypotension, okay, your blood pressure is dropping, the stretch in these receptors is dropping. Okay. Whenever the stretch in this receptor is gone, the afferent baroreceptor firing is gone. And when the baroreceptor firing is gone, you have the activation of the sympathetic nervous system. Very important. As long as the baroreceptor firing is there, the parasympathetic nervous system will be activated. Okay. But as soon as you have the hypotension, what's going to happen? The stretch will be lost, the afferent firing would be lost, and because of this loss of the afferent firing, just give me a second. Because of the loss of this afferent firing, okay, you can have an activation of the sympathetic nervous system and the deactivation of the parasympathetic nervous system. So you will get the vasoconstriction and increase in the heart rate, increase in the contractility, and ultimately increase in the BP. Okay. Whenever you do a carotid massage, very important, whenever you do a carotid massage in a hypertensive patient, what's going to happen? The pressure inside the carotid sinus will be increased. And as a result, the stretch of the baroreceptors will be increased. When the stretch is increased, the afferent firing is increased. And as a result, you can have a lower down of the heart rate because of the AV node increase in the AV node refractory period. By the parasympathetic nervous system, you will have the muscarinic activation, the M2 receptors. Okay, they will be activated and they will cause the decrease in heart rate. Okay, and as a result, the decrease in the blood pressure. So whenever you encounter a patient with the arrhythmia sometimes or with a high BP, you will do the carotid massage in these patients. Okay, if no drug is available at the time, you will do the carotid massage to prevent the kind of these arrhythmias in the patient. Okay, very important, the carotid massage. Okay, then you need to know about the Cushing reflex. Whenever you have a intracranial hypertension, okay, or a very high pressure inside the brain, what gonna have? You will have the triad of the hypertension, the bradycardia, and the respiratory depression. Very important. Whenever you got a patient in a, let's suppose a patient is having some kind of a brain hemorrhage, okay, and now he is having an intracranial hypertension, okay, or a very raised intracranial pressure. Now, due to the rise of this pressure inside the cranium, what's going to happen? Three things: the hypertension, the bradycardia, and the respiratory depression. Because of the increased intracranial pressure, okay, the arterioles in the brain will be constricted. So you will get the cerebral ischemia. Okay, now because of the cerebral ischemia, the CO2 will be raised and the pH will be fault, right? And as a result, the central reflex sympathetic increase in the perfusion pressure. Okay, the perfusion pressure will be increased in order to increase the blood inside the brain. Okay, sympathetic system will be activated inside the brain, and as soon as sympathetic system will be activated, rest of the body was normal. it was a condition only in the brain. So these receptors, they are in the periphery, they will become activated. Okay, the stretch will be there. Increase in the stretch will lead to the activation of parasympathetic nervous system, and that's why you will get the bradycardia. So you get a triad of the hypertension, the bradycardia, and the respiratory depression. So whenever you encounter a patient, okay, and in the lab reports, the patient is having a hypertension, bradycardia, and the irregular breathing, or sometimes the apnea, you can immediately know the patient is dying. Okay, and why the patient is dying? The patient is dying of the increase in intracranial pressure. The patient must be having any herniation of the brain, or maybe a brain hemorrhage. Okay, so whenever you study a question stem, and in the question stem, they will always give you labs. Okay, they will give you the BP reading, the heart rate of the patient always, and and the breathing rate of the patient. So whenever you encounter this triad, high BP, low heart rate, and bradycardia, and this apnea, you will immediately know the patient is having any brain problem. The patient might be having any hernia or any kind of increase in the intracranial pressure. So very important is Cushing reflex. Okay. Similarly, in case you have the hypertension, what's going to happen because of the hypertension, like we have discussed, you will have an increased stretch of these receptors. And because of the increased stretch, what's going to happen? They will increase their firing. Okay. The signals will be go to the medulla. Okay. And in the medulla, the sympathetic system will be shut down and the parasympathetic firing would be increased. It will go to the heart. It will cause the bradycardia. Okay. Then comes the chemoreceptor function. The chemoreceptors, they mainly respond to the CO2. The CO2 in the blood, they will respond to it. Okay. And for the peripheral, for the central, they have two, the CO2 as well as the pH of the blood. And when the PO2 is dropped below 60, very important, only when the PO2, the partial pressure of the oxygen, when it dropped below the 60, only then these receptors will be respond to the oxygen. Okay, very important. They generally respond to the CO2 and the pH. Okay, but only when the oxygen is dropped below 60, they will respond to the oxygen. When you have low oxygen, they will be activated kind of, and you have a high breathing rate. Okay, and when this O2 is increased, okay, the breathing of the patient will be decreased only if it is below the 60. Okay. Then you have the central chemoreceptors, which only respond to the CO2, not to the pH, because the hydrogen ions cannot cross the blood-brain barrier. Okay, so they directly responds only to the CO2. Okay, and they will never respond to the PO2. Very important. Only the peripheral chemoreceptors respond to the oxygen whenever the oxygen drop below 60. Central chemoreceptors, they do not respond to the oxygen. Very important. Now, in case of a COPD, because in the COPD patient, they have a chronically increased CO2 and a decreased in the PO2. Okay, so because of the chronically increased in the CO2, the receptors will become less responsive to the high CO2 levels. Okay, and instead, the peripheral receptors, they will be responding to the oxygen. Okay, now because the patient has a low oxygen, the breathing rate of these patients will be increased. Now, in the scenario where you give the patient 100% oxygen as a therapy, what's going to happen? The PO2 level of these patients will be increased. And because the PO2 level of these patients will increase, you will see the bradypnea in these patients. Very important. Whenever you give a oxygen therapy, a high oxygen therapy to a COPD patient, you will always have the bradypnea or the apnea sometimes. Why? Because of the sudden rise in the oxygen. Because in case of a COPD, the peripheral receptors, they will be responding to the oxygen. Okay, and they will not be responding to the CO2 anymore because of a chronically increase in the CO2. Similarly, for the central receptors, they won't be responding to the CO2. Okay, and as soon as you give them the oxygen therapy, the CO2 level will rise. And when the CO2 level will rise, what's going to happen? You have a fall in the respiratory rate. You will see that the patient is having a bradypnea. Okay, and this is one of a cause of oxygen induced this hypercapnia in the COPD patient. Very important. You will study that later in the respiratory section. The oxygen induced hypercapnia, and one of the cause of this is the this sudden increase in the O2 levels. Okay. So that's about the carotid sinus massage. We have discussed the baroreceptor firing. And one important disease or a pathology is the carotid sinus hyperactivity. It is generally seen in the old age patients or some patients who have any kind of a neck surgery for like a thyroid gland surgery. Okay, in these patients, the carotid sinus become hyperactive, very sensitive to the touch. Okay, so whenever the patient try to, to, whenever the patient try to wear a tie, okay, or try to button a shirt or try to shaving sometimes, what's gonna happen? They will touch the receptors, and because of a slight touching of the receptor will become activated. Okay, and patient will see a bradycardia, a low heart rate, hypotension, and ultimately the patient will fall because of the syncope. Okay, very important because of the high sensitivity of the carotid sinus. Even a slight touch on the sinus will lead to the activation of these sinuses that can lead to the parasympathetic activity like bradycardia, hypotension, and syncope will occur. The patient will fall. Generally seen in the old age patients or the patients who are having a history of any kind of neck surgery. Okay, and the case is generally seen while shaving, while tying the tie, okay, while buttoning the shirt. Okay, these three scenarios, please remember. Okay, and the patient also have an increased risk of atherosclerotic disease in them, right? So step one will ask you this: what is the cause of syncope in this patient? It would be the increase in AV node refractory period because of increase in the parasympathetic firing by the carotid sinus. Please remember, it is not the aortic sinus, it is the carotid sinus. Okay, any doubt on this page?
Yes, sir. I had one question.
Yeah, please ask.
When we were talking about the B-type natriuretic peptides, you mentioned an enzyme and then a pharmaceutical for the enzyme. Can you type out in the chat box with those two, that
The name,
enzyme
the name you are asking.
Yeah, the names for both.
Let me type that for you.
Thank you.
Is that okay?
Yes, sir. Thank you.
Thank you. Okay, so that's about the ANP, BNP, and the baroreceptors and the chemoreceptors. Please remember your, the heart and your the CVS system. They're mainly under the parasympathetic response initially. Okay, because of this high activity of these receptors. Okay, only when the activity of these receptors are gone, then you can have the activation of sympathetic nerves. Okay, and then these chemoreceptors, they only respond to the CO2 and the pH, the peripheral ones, and the central ones, they only respond to the CO2. Okay, only when the oxygen level drop below 60, the peripheral chemoreceptors, they will be responding to the oxygen. Okay, and that is one of the cause in the this oxygen induced hypercapnia, one of the cause of the this oxygen induced hypercapnia in the COPD patients. Because a COPD patient, they have a chronically increased CO2, so the receptors kind of become very desensitized with the CO2, and they will be start responding to the oxygen, only the peripheral ones, right? And as soon as the oxygen level rise in the body, what's gonna happen? You will have the shutdown of the respiratory rate or the respiratory system, and that's why we get the hypercapnia and the apnea also. Very important. And remember this carotid sinus hypersensitivity and the carotid massage. Then you need to know about the normal pressures in the cardiac system, in the heart, in different chambers, and this you can measure with the help of pulmonary capillary wedge pressure, the PCWP. Okay, and it is measured by the Schwann-Ganz catheter. Very important. You will measure the PCWP with the help of Schwann-Ganz catheter. Okay, what's gonna happen? You will first insert the catheter into the jugular veins. From there, it will go to the superior vena cava. From the superior vena cava, it will enter to the right atrium. Okay, it will note down the pressure of the right atrium. Okay, and please remember the pressure in the right atrium, which is the right atrial pressure, if anyone remember, is between
0 to 5.
0 to 5. Exactly. So the pressure in the right atrium would be 0 to 5. Okay, very important. Then this catheter will be go to the this right ventricle. Okay, in the right ventricle, the systolic pressure is 25. Okay, and the diastolic pressure is 5. Can anyone tell me why the diastolic pressure is 5?
Because it's the same pressure that atrium has at the end of diastole.
Why is that? Why the same pressure?
Because ventricle fills with this pressure.
You can think it like, see, in case of diastole, remember these valves will be opened. These valves will be opened, right? The tricuspid valves. So now the atrias and the ventricles are kind of one chamber when the valves are open, right? And because they are become one chamber, the pressure must be equal in between these two, right? We have discussed this previously. I have told you whenever you have an opening of a valve, now the chamber is become one chamber, okay, closed one, and that's why the pressure must be equal in between these two, right?
Yeah.
We have seen the graph also. The pressure always goes side by side in case of iota and loop, right? So please remember that. Now, when the catheter will go to the pulmonary artery, okay, and in the pulmonary artery, it will measure the pressure of 25 by 10, okay, because in case of a systole phase, the ventricles contract, these valves will open, okay, and when the valves are open, now these artery, the pulmonary artery, and the ventricles are kind of a closed system, so the pressure must be equal between these two in case of systole. So 25 and 25. In case of diastole, the valves will be closed because of the high pressure inside the pulmonary artery. So pressure must be high. The diastole pressure must be high inside the pulmonary artery, which is kind of 10 mm of Hg. Okay. Now at that point of time, you will just inflate the catheter, and the catheter will cause a blockage in the artery. Okay. And because of the blockage, a continuous blood column will be formed between the left atrium and this catheter. Okay, you understand this?
No. Repeat it,
See,
please.
let me annotate it so that you can have a better understanding. See, this is your right ventricle. Okay, this is your left atrium. Okay, this is your left atrium. This is the right ventricle. Okay, you have the pulmonary artery here from the right ventricle, and then it will divide into different branches. Okay, smaller branches, and all of them will go to the left atrium, right? Like that, via pulmonary veins. Okay, now what happened? I've inserted a catheter. Okay, and the catheter will go all the way back into the smaller branches of the pulmonary artery. Okay, and it will cause a blockage there. Okay, now because the blood is already filled, uh, just a second, because the blood is already filled in these arteries. Okay, the blood is filled already, as you can see, like that. A continuous column of the blood is formed between the left atrium and this catheter. Is that okay?
Yes.
Now, whenever the pressure inside the left atrium increased, the pressure will be transmitted through this artery, right? Yes.
Yes.
And whenever the pressure is transmitted through this artery, what's gonna happen to the blood column? The pressure inside the blood column will be increased.
Yes.
Yeah. And that pressure will be noted by the catheter. Okay. So it is because of this blood column, it will note down the pressure inside the left atrium. Whenever the pressure inside the left atrium is increased, it would be easily measured by the catheter, right? So this is the Schwann-Ganz catheter. It will block the artery so that a continuous blood column will be formed between the left atrium and the catheter. Okay, and this column will represent the pressure inside the left atrium, because ultimately same blood is present in the left atrium also. So a continuous column between the left atrium and the catheter, right? Any doubt on that?
No doubt. Does it is specifically identify pressure in systole or diastole, or it continuously recorded?
It continuously recorded, yes,
Okay, thank you.
continuously. Okay, so as soon as it kind of block this artery, it will represent the pressure inside the right atrium, and the pressure is around 10 to 12 mm of Hg. Okay, very important. The pressure inside the right atrium is 10 to 12 mm of Hg. Okay, now if you insert the catheter furthermore, and somehow you can reach the this left ventricle, it will represent a pressure of 130/10 in the left ventricle. Okay, the pressure inside the left ventricle is 130/10. Okay, and because the systolic pressure is 130, and why the diastolic pressure is 10? Because in case of a diastole, this atrium and the ventricle, they are kind of a closed chamber, right? One thing. Okay, and that's why whatever the pressure inside this auricle is, the same pressure should be inside the ventricle also, right? So the diastolic pressure must be equal between the two. Okay, 10 to 12 and 10 to 12. For a systolic pressure, when the ventricles contract, this the aortic valve will be opened, and now this aorta and the ventricles are in a close connection, and as a result, whatever the pressure inside the ventricle is in the systolic phase, the same pressure should be inside the aorta also. So in the aorta, you have a systolic blood pressure of around 130. Okay, the diastolic pressure must be high in order to close these valves, so that the valves could be closed. Okay, and you have a diastolic pressure of 90 in the aorta. Okay, so for the right atrium, the pressure is 5 mm of Hg. For the right ventricle, the pressure is 25/5. Okay, for the pulmonary artery, the pressure is 25/10. For the left auricle, the pressure is around 10 mm of Hg. For the left ventricle, the pressure is around 130/10. Okay, and for the aorta, the pressure is, you already know, 120/80 or 130/90. Okay, any doubt on this normal cardiac pressures?
No, sir.
Okay, so yeah, that's. So can anyone tell me which organ in our body receives 100% of the cardiac output?
Brain.
Brain.
It's heart.
It's heart. Try something more other than the heart. Heart is actually giving the cardiac output. Which one is receiving the cardiac output?
Lungs.
Lungs, exactly, through pulmonary arteries, because whatever the blood inside the right heart should be go into the left heart, right? And it would be travel through the lungs, the pulmonary artery. This pulmonary artery actually carries 100% of the cardiac output. And that is a difference between the pulmonary artery and the bronchial arteries. The bronchial arteries, they carries a fraction of the cardiac output. Okay, and it supplies the oxygen to the lungs, the different part of the lungs, like the trachea and all these bronchi, bronchioles, alveoli, right? While the pulmonary arteries, they carries the 100% cardiac output. They will go to the lungs, they will exchange the oxygen, and they will bring it back to the this left side of the heart, right? Step one can ask you this 100%, this difference between the bronchial arteries and the pulmonary arteries. And this is a major difference. The pulmonary arteries, they carries 100% cardiac output, right? Very important. Then comes the autoregulation. Okay, and autoregulation is actually a thing whenever you lost a blood supply to a certain organ, right? It not just not the oxygen supply, but the BP of a certain organ. Whenever you losses the BP in a certain organ, it's not just the blood supply is lost with the BP. Certain organs, they have a mechanism to maintain the blood pressure in case of the hypotension, right? So one of them is the heart. Whenever let me take you forward. Oh, I think I've missed the page. Just give me a second. Uh, I think I forgot to take the pictures of that page. Okay, no worries. I will annotate it. No worries. See, in case of heart, what's gonna happen? See, let us suppose this is the blood pressure in the heart normally. Okay, at this point. Okay, and now you are having a hypertension. Okay, so this is the BP part, blood pressure. Okay, the blood pressure is rising. Okay, now when the blood pressure is rising, it's not like the organ is having a high blood pressure. Okay, the central blood pressure is rising, but the organs have their way to maintain the blood pressure. And how does the heart gonna maintain the blood pressure? It is by the release of the nitric oxide, the CO2, okay, and the adenosine. See, the heart has the ATP, the adenosine triphosphate. When this just a second. Yeah, in case of a hypertension, what's gonna happen? The adenosine values will be lower down, the nitric oxide will be lower down, and the CO2 will be lower down. Now, all these three things, the adenosine, the nitric oxide, and the CO2, they are the vasodilatory substances in the body. Okay. So whenever you have the hypertension, the concentration of these substances in the heart blood, in the coronary blood, it will be dropped. And as a result, the coronary blood pressure will be lowered. Okay. So whenever you have the hypertension, in the arteries, what's going to happen to the coronary arteries? They will decrease the concentration of adenosine, nitric oxide, and the CO2. And as a result, the blood pressure will be normal inside these coronary arteries. Okay, it will be normal up to a certain value. After a certain value, if the blood pressure further increases, then the blood pressure inside the coronary arteries will also increase. Okay. Similarly, if you have a case of hypotension, okay, then heart will get the ischemia, and because of the ischemia, the heart has the ATP. The ATP will be used out, and ultimately the adenosine will be released from these ATPs. Okay, the CO2 will be released by the heart, the nitric oxide will be released by the heart, and because of these three things, the vasodilation of the coronary vessels will occur. Okay, and because of the vasodilation, what's gonna happen? The blood supply in the coronary arteries will be increased, the pressure will be increased. Okay, but again, this is only up to a certain value, a certain limit. Okay, after a certain limits, if the pressure is further dropped, what's going to happen? You will also have a drop in the coronary blood pressure. Okay, so in case of a hypertension or the hypotension, the heart or or and many other organs, they have their way to maintain the same blood supply and same blood pressure, and this is known as the autoregulation. So how blood flow to a certain organ remain constant over a wide range of pressures. This is the autoregulation, and that's how the heart regulates its blood pressure, right? Whenever you have a hypertension, what's going to happen? This adenosine, nitric oxide, CO2 will be decreased. As a result, the vasoconstriction will happen, and that can lead to the lower down of this organ perfusion. Okay, in case of a hypotension, these substances will be released by the heart, and as a result, you will get a vasodilation and increase in the blood pressure and the blood flow. Okay, but after certain limits, this autoregulation mechanism will be lost, and you will get the hypertension and the hypotension similarly, right? Any doubt on height?
No.
Okay, so in case of a brain, you have the vasodilated substance, which is the CO2. Okay, your brain actually responds to the CO2 only. Okay, whenever you have a high CO2 value, you will have a vasodilation in the brain, and the brain blood supply would be increased. And whenever you have a low CO2 value, vasoconstriction will be happen in the brain, and as a result, the blood flow to the brain will be decreased. Okay. So in case of a hypercapnia, what's going to happen? The vasodilation and blood flow will be increased. In case of hypocapnia, what's going to happen? The vasoconstriction and the blood flow to the brain will be decreased. And that is a mechanism why you give the patient very high oxygen therapy in case of the accidents. Okay. You will decrease the CO2 values, and as a result, the blood flow to the brain could be decreased, and that can relieve the intracranial pressure. This pressure. Okay. So whenever you are having a brain hernia or a high increase in the intracranial pressure, one of the way to relieve the pressure is to give the patient high oxygen therapy or the low CO2 therapy, not a high oxygen, but a very low CO2 therapy. And because of this low CO2 therapy, the vasoconstriction inside the brain will occur, and that can relieve the this intracranial pressure. Very important. Okay. And this is known as a therapeutic hyperventilation. Okay. This is known as the therapeutic hyperventilation. Very important. It is used to treat the acute cerebral edema, generally which happens secondary to the strokes. Okay. Any doubt?
What does hypoxia causes in case of heart? Like it causes vasoconstriction, isn't it?
In case of hypoxia,
Yeah, in the heart section, it is written low oxygen.
see, in
So it
case of
causes
hypoxia, these are
vasoconstriction, right?
in case of hypoxia, you will have the adenosine and this NO and the CO2 released, so that it can cause the vasodilation, not the vasoconstriction. In case of hypoxia, you will have the vasodilation. See, in every scenario, the heart will try its best to prevent the ischemic conditions. Okay. Only when all these things, only when that, remember I told you about the stress thing in the general path section when we're discussing about this hypertrophy and the atrophy things. Remember, I've told you, whenever the stress will there, whenever the stress is there, your organ, your tissue will try everything, to adapt to it, right? Only when the stress is exceeds its limit, the injury will occur. Same case in case of myocardial infarction. Initially, when the blood supply is lost to a certain organ, like in case of heart, right? The heart will try everything. It will lower down its values, heart rate, and it will undergo something known as this the myocardial hibernation process. You will study that later in the chapter about the myocardial hibernation. Okay, where the heart will lower down its metabolic demands to meet the oxygen requirements, right? Similarly, it can cause a vasodilation. So heart will try everything to prevent ischemia. Only when everything is exceeded now, only when this the hypoxia is exceeded to the adaptation limit, the infarction will occur. You understanding what I'm trying to say?
Yeah, I got it, but I was confused about in the line it is written hypoxia generally causes vasoconstriction in all the body parts except in the lungs.
Hypoxia causes vasoconstriction in lungs, and generally it will cause vasodilation. See, in other organs, hypoxia causes vasodilation. Only in the lungs it will cause a vasoconstriction. We will study that again later in the pulmonary, in the lung section. Okay, the pulmonary this hypoxic vasoconstriction, it only occur in the lungs, not in other organs. Okay.
Okay, got it now. Thank you so much.
So now if I try to draw the any chart for the brain, let's draw a diagram. So for the brain, like I told you, it will be responding to the CO2. Okay. And this is the cerebral blood flow, C, B, F. Okay. And this is the pressure. Okay. Now, whenever the CO2 pressure is rising, like in this scenario, whenever the CO2 pressure is rising, what's going to happen to the cerebral blood flow? It would be, tell me, increased. Exactly. Whenever the CO2 is rising, cerebral blood flow will be increased, but only up to a certain limits. When the certain limit is reached, and like say, I think it was around 90, I think. Okay. when the PCO2 become 90, the heart will stop responding to the CO2, okay, and it will become very constant. Okay. Similarly, at a very low oxygen levels, when the PO2 become less than 50, only then the brain will start responding to the oxygen. Okay. So if this is a scenario, this is a lower down of the oxygen, and let's say at that point the partial pressure 50 is lost, is reached. Okay. So up to this point, the brain will not be responding for the oxygen. Okay. When the partial pressure of oxygen reached below the 50 limit, the 50 mm of Hg, okay, then the vasodilation in the brain will occur and the cerebral blood flow could be increased. Is that okay? This graph is for the CO2. Okay, when the CO2 is rising, the vasodilation will be occurring. Okay, but after certain limits like 90 mm of Hg, the response to the CO2 is lost and the blood supply will become very constant. Okay, in case of oxygen, the brain will not be responding to the oxygen up to a level of 50 mm of Hg. Only when the oxygen level drops below the 50, the brain will start responding to the oxygen, not to the CO2. And as a result, with a further drop in the oxygen, you will have a vasodilation that will increase the cerebral blood flow. Is that okay?
Yes.
Then comes the kidneys. Okay, for the kidneys, you have the myogenic and the glomerular feedback. We will study that later in the renal section also. Okay, how the RAS system works, how the aldosterone works. Okay, so just wait for the moment. They have two mechanisms, but one is the myogenic mechanism, which is by the dopamine receptors, and second is the tuboglomerular receptors, which is by the RAS. Okay, so they will maintain the GFR, the filtration fraction, and the renal blood flow. Okay, then comes the lungs. In lungs, you have a special case. In case of lungs, the hypoxia causes the vasoconstriction, while in other organs, the hypoxia was causing the vasodilation. In lungs, the hypoxia causes the vasoconstriction, and this is a mechanism to prevent the VQ mismatch in case of any hypoxia conditions. Okay, when a certain alveoli become very kind of defective, like any blockage if happens. Okay, let's suppose this is the alveoli. This is the alveoli, and this is the blood supply to the alveoli, right? Whenever the oxygen to this alveoli is lost, okay, what happens? The vasoconstriction of that area is lost, so that the blood could be this blood could be transferred to other places where the oxygen supply to the alveoli is rich, very high. Okay, and this is to prevent the VQ mismatch. Very important. This is to prevent the VQ mismatch. Whenever certain alveoli become dysfunctional, like any kind of a blockage happen, and the oxygen to this alveoli is lost, okay, the blood which was supplying to this alveoli, it will also be lost. It will be vasoconstriction happen, and as a result, the blood will be diverted to other areas of the lungs where the oxygen is very rich, and this is to prevent the VQ mismatch. You will study that later again in the respiratory section. Okay, so if I try to draw a graph for the lungs, what's going to happen? Like this is the vascular resistance or the vasoconstriction, and this is the oxygen. So whenever the oxygen level is dropping in this direction, what's going to happen? The vasoconstriction will be happening in this direction. Okay, so as you can see, this graph will be formed. As the oxygen supply is lost to the alveoli, the vasoconstriction will be happened, and this is to prevent the VQ mismatch. Special case for the lungs, right? While in other areas, in other organs, if I draw the similar graph, when the PO2 is decreased in this direction, what's going to happen? Vasodilation. The vasoconstriction will be lost and you will get the vasodilation like that. Okay. So for the lungs, it is a special case. You guys understand this? Are we good?
Yes.
Yes, it's clear.
Okay, then comes the skeletal muscles. Similar to the heart, if the blood supply to the skeletal muscles is lost, hypoxia occurs. In that condition, CO2 will be released, hydrogen ions will be released, adenosine will be released, lactate will be released, potassium ions will be released, and all of them can cause the vasodilation. Okay, all of them can cause the vasodilation. And this similar thing will be occurred in case of exercise. Whenever you have a high metabolic demand, okay, the blood supply must be increased to meet the metabolic demands. So in that case, the vasodilation will occur, and this is by the CO2, adenosine, lactate, potassium, and hydrogen ions. All of these things can lead to the vasodilation. Okay, then comes the skin. We already know that it is under the sympathetic control, the alpha-1 receptors. Okay, whenever you have a high temperature, what's going to happen? The alpha receptors would be kind of not stimulated. Okay, as a result, the vasodilation to the skin will occur. The blood supply to the skin will be increased. That can cause the flushing. Okay, so that the heat could be transferred. Okay, so whenever you have a high temperature, you will always has the flushing. Why? Because of the vasodilation of the skin. Okay, are we good up to here?
Yes.
Okay, then comes the capillary fluid exchange. Okay, three things are there. I think two things are there only. One is the pressure of the blood. Okay, the partial pressure, and second is the oncotic pressure. Okay, whenever the blood pressure is increased inside a vessel, what's gonna happen? The transfer or of the fluid, okay, will happen from the capillaries. And please remember, it is by the capillaries, not the arteries, not the veins, by the capillaries. Okay, oncotic pressure kind of opposes this thing. Okay, exchange. Oncotic pressure opposes this exchange, and the pressure, the partial pressure or the hydrostatic pressure, I must say, the hydrostatic pressure, it will promote the exchange. Very important. The PC represent the capillary hydrostatic pressure. The similar hydrostatic pressure you have in the interstitium, known as the interstitial hydrostatic pressure. Okay, you have the oncotic pressure in the capillaries, which will oppose the exchange, and you also have the oncotic pressure in the interstitium, which will kind of promote the exchange. Okay, now you have a net fluid flow, which is depicted by the equation. This is the constant, which is the permeability to the fluid. Okay, the difference in the hydrostatic pressure of two areas minus a reflection coefficient and the difference in the oncotic pressure in these two areas. Okay, you can remember that formula. Very easy. Okay, and whenever the exchange is increased, what's going to happen? After the interstitium, you have the lymph vessels here, right? Which will collect all the fluid inside the interstitium. It will take it to the lymphatic vessels. It will take them to the lymph nodes, and it will enter in the lymphatic system, right? So whenever you have a fluid exchange, the fluid will be present in the interstitium. All of that fluid will be collected in the lymph vessels. It will be taken up to the lymph nodes, and from there it would be entered into the lymphatic system. So whenever you have an increased exchange, the lymphatic flow will always increase, and this is to prevent the lymphedema. This is to prevent the edema in the body, because whenever you have an increased interstitial fluid, you will always have an edema. And the primary mechanism to prevent the edema in case of heart failure, even, it is to increase the lymphatic flow. Okay. So first thing is the increase in the capillary pressure that could be seen in case of a heart failure patient or in case of a saline injection. Okay, you will have an increase in the hydrostatic pressure inside the capillaries. The fluid volume inside the capillaries is increased. As a result, the exchange will be increased. Okay, the interstitial fluid will be increased. Initially, the lymph vessels will try to overcome this. Okay, but ultimately, what's gonna happen? The interstitial fluid, it will overcome this lymphatic flow, and then that time the edema will occur in the body. Okay, second case, whenever the toxin happen, whenever the infection happen, whenever the burns happen, okay, the permeability of the capillaries will be increased. Okay, it is by the release of some hormones like the histamine, the serotonin, okay, the prostaglandins, and the leukotrienes. And second thing is by the direct damage of the endothelium that can lead to the increase in capillary permeability that can cause the edema. Okay, and that's why you have the swelling over the area of the infection or the injury, right? Because of this edema. Third thing is the increase in interstitial fluid colloid osmotic pressure, which could be happen in case of any lymphatic blockage. If the lymphatic blockage happen, then this interstitial fluid could be increased, and that can lead to the edema also. Okay, And this thing can be happen in case of a tumors. Sometimes what happen, the tumors which will be metastatizing from the this lymph nodes, okay, like all the carcinomas, what going to happen, ultimately they will cause a lymph blockage that can lead to the edema in the body, right? If the plasma proteins are dropped, like in case of a malnutrition, in case of a liver failure, because the liver actually synthesizes the these all the proteins, the maximum proteins, okay. And in case of a nephrotic syndrome, where you have the where you are losing the proteins from the body, okay, this can all lead to the loss of plasma proteins, and the proteins are responsible to maintain the osmotic pressure, okay. So the osmotic pressure will be lost in case of a loss of protein, for if the synthesis of the protein is decreased, or the loss of protein is increased, that can lead to a decreased protein in the body, and that can lead to the edema also, okay. Very much important. And the major protein which is responsible for the maintenance of the osmotic pressure is your albumin, okay, and which is synthesized by the liver, okay. And you will lose the albumin in case of nephrotic syndrome, okay. So that's how you can get the edema. Very important. So any doubts so far?
No.
Here, interstitial fluid colloidal osmotic pressure, it means the colloidal pressure, osmotic pressure will rise in between interstitial space.
Yeah, within the interstitial space, yes.
Okay.
Okay, so we have discussed the serious changes during the exercise already. Okay, sympathetic system will be activated, that will increase the heart rate, okay, that will increase the contractility, that will increase the cardiac output, stroke volume, okay. And heart rate is mainly, and like we have discussed initially, at the very initial time, the heart rate and the stroke volume, they both will be contribute to the increase in cardiac output. But in the later stages, only the heart rate will be responsible for the maintenance of cardiac output, right? The sympathetic system activation will cause the the vasoconstriction of the skin, but the vasodilation of the skeletal muscles will occur, so that the blood supply to the skeletal muscles could be increased, okay. Overall, you have the a kind of balanced vasoconstriction and the balanced vasodilation, right? Very important. And so you have a maintained diastolic blood pressure, okay, a maintained diastolic blood pressure, but a very raised systolic blood pressure, right? Both the left ventricular and diastolic volume and pressure will be raised in the exercise, okay. The pulmonary arterial systolic pressure will be increased, okay. And you will also get a vasodilation of the pulmonary vasculature in case of exercise. Very important, you will have the vasodilation in the pulmonary vessels in case of exercise, so that more oxygen could be exchanged and more oxygen could be delivered to the tissues, okay. So increased blood flow to the pulmonary circulation. Very important. That's the case about exercise. So I think we have done with the physiology section completely. Okay, any doubt on this page?
Can we discuss age-related changes, physiological changes in CVS?
Yeah. See, age-related physiological changes in the heart or in the complete CVS, you are asking?
In the CVS.
See, in case of the blood vessels, what going to happen to the compliance? The compliance will be increased, right? And because the compliance is increased, the compliance is decreased, right? Yeah. And the vessels become very stiff, and because of the stiffening of the vessels, what you can have is the very high pulse pressure, right? So you have a very high systolic blood pressure and a normal diastolic blood pressure, so you will get the isolated systolic hypertension in case of old age, okay. In case of heart, you will get the atrophy of the heart. Very important, you will have the atrophy of the heart in case of old age, okay. The distance or the size of the heart from apex to base is increased, okay. I think I've mentioned it somewhere. Let me check where I've mentioned this part. The age-related changes in the heart, very important it is to recognize them. In case of heart, the apex to base that dimension, the size from the apex to base of the heart will be decreased. Okay. The size of the left ventricular chamber would be decreased. Okay. And the septum between the two ventricles, the interventricular septum, it will acquire the sigmoid shape. Very important. The step 1 will mention this on the autopsy of the patient. What you will see, sigmoid shape of the this interventricular septum. Okay. And we have already know the deposition of the collagen and the transthyretin will be increased with the aging. So you will get a kind of increased thickness of the left ventricle. You can also get the restricted cardiomyopathy sometimes. Okay. You will get the senile amyloidosis in the old age. Okay. And there's a one pigment like we have discussed in the previous sections in the general pathology, the lipofuscin pigment, if you guys remember, which is the age-related pigment due to the wearing and tearing with the age. Okay. And that can lead to the brownish with deposits on the cells, on the extracellularly, that you can see on the microscope. Okay. So on the autopsy of the heart, you will see the small size of the heart. Okay. Apex to base will be decreased. Okay. Sigmoid shape of the ventricles would be there, of the interventricular septum will be there. Okay. And the thickness of the ventricles would be increased because of the amyloidosis. On the biopsy of the patient, you will see the brownish with deposits on the cells. Okay. The cytoplasmic pigment would be there, and that would be the lipofuscin. Okay. And in the vessels, you will get the isolated systolic hypertension. Is that okay?
Due to aging, the shape of the interventricular septum changes to sigmoid, or the ventricular cavity changes to sigmoid?
Interventricular septum.
Okay.
Septum will be changed to sigmoid shape. Very important. Step 1 will give you this description of a heart. The apex to base will be decreased and the sigmoid shape would be there, and some kind of a brownish pigment deposits are there. So do not confuse it with the hemochromatosis or this the melanoma. Okay. Do not confuse it with this. If it is an old age patient and you have this kind of a heart description, it must be the age related changes. Okay.
And in hypertrophic obstructive cardiomyopathy, do we have similar septal changes?
No, not in case of no. In case of the restrictive this cardiomyopathy, you can have this increase in the thickness of the wall, but not the sigmoid shape. Okay.
Okay. Thank you.
It is very specific for the aging only.
Okay.
In aging, what does happen with compliance?
The compliance would be decreased and the stiffening of the vessels will happen.
Why compliance decreases?
Well, that's a question of kind. I really don't know why the compliance is decreasing.
Sclerosis.
Yeah, man things are there actually in the aging.
Yeah.
Actually,
Sclerosis
doctor,
is one of
once there is a aging, so the vessels become stiff. So that's why
yes,
they cannot be stretched. So that's why the
yes,
compliance is decreased.
Yeah.
yeah. Of course, that's
Yeah,
the reason for
exactly.
compliance.
Stiffening mainly occurs in arteries, not in
Loss
veins.
of loss of compliance is known as this stiffening. Yes, loss of compliance is known as
Yeah.
stiffening. So if you're asking definition, that would be okay. But why the stiffening is occurring, I really don't know why the stiffening is occurring. It's kind of age-related thing. By the deposition of collagen, I think, maybe in the vessels.
Yeah,
And you have
could
one more
be
thing.
age
And remember
related.
one more thing, it would be this something known that I'm forgetting one thing. We have discussed in the Marfan syndrome. What happened to this the tunica media in case of Marfan syndrome, if anyone remembers?
Cystic degeneration.
Yeah, cystic degeneration will also occur. That can lead to the degeneration of the elastic fibers. Okay,
Yeah.
and the collagen also, so that the strength of the vessels could be lost and the elasticity of the vessels is also lost, kind of things, right? So
Right.
aneurysms can also happen. These are all
Mm.
the age-related changes will happen in case of aging, right?
Yeah, okay. Get it.
Okay.
Okay, so let's take a short break for 5 to 10 minutes. Okay, and we'll meet again.
Okay.
Yes.
For an important concept, time for important concept. Can anyone tell me, like I told you, when you increase the hydrostatic pressure, okay, when you increase the hydrostatic pressure, you will have a fluid exchange and the interstitium fluid volume will increase and you will get the edema. Then why not in case of a hypertension, you will get the edema? If you encounter a patient of hypertension, you won't see any edema, although the blood pressure is very much rising in the patient. Why don't they get the edema?
Lymphatic drainage.
Let's kind of okay thing, lymphatic drainage, but that's not the reason actually.
Aldosterone escape
What?
because of aldosterone escape.
No, not the aldosterone escape. See, the interstitial fluid was absolutely normal in case of a hypertensive patient. They're not even getting exchange of fluid. Even though they are having a hypertension, they are not having the exchange of this fluid. That was the case. The lymphatic drainage will only help when the interstitial fluid is increased, when the exchange was there. But in the hypertensive patient, even the exchange is not there. You won't have the leakage of the fluid from the capillaries. Why is that so? Even though the patient is having a hypertension, he's not having the exchange of the fluid. No edema.
Does it has to have something because with arterioles, like so arterial
Yeah, exactly. See, where do you measure the blood pressure of the patient?
Artery.
Arteries, right? And where does the exchange happens?
Capillaries.
Exactly. So in case of a hypertension, you have the constriction of the arterioles. That will raise the blood pressure, right?
Yeah.
But after the constriction of the arterioles, you have the capillaries, not before them, right? So whenever you constrict the arterioles, you're actually reducing the blood flow to the capillaries. And that's why the hydrostatic pressure is kind of lower down, not increased, but lower down. And that's why you get the, you won't get the edema, right? That's the reason, because of the arterioles. Now, in case of increased blood volume, what gonna happen? See, let me change the question again. Like I told you, in case of a hypertension, you're not having the edema. Why in case of heart failure you are having the edema? Oh, sorry, not like that. Let me change the question. Yeah, you have a patient of heart failure, and he's not having the edema yet. He will develop the edema later. But what is the one thing which is preventing the edema in case of a heart failure very initially?
ANP and BNP, they may lead to necrosis.
They came later in the picture, not before. The very first thing that I told you, very important thing to prevent the edema in a patient.
Decrease oncotic pressure?
No. See, the exchange is there in case of a heart failure patient. The exchange is there, the leakage is there, the interstitial fluid is rising, but the one thing is preventing the edema. I've discussed this already. Yeah, exactly, lymph drainage. So the important concept is whenever you have the hypertension belongs to the arteries only. Okay. And because the arterioles come later and the capillaries also come later in the picture, you won't get the edema because of the constriction of the arterioles. But when you get the increased pressure in the veins, like in case of heart failure, because you have a backflowing of the pressure completely in the veins, right? The exchange of the fluid will be there. Okay. And in that time, the lymph drainage will be preventing the edema. Okay. So the lymphatic drainage would only be increased and will be preventing the edema in case of heart failure patient, not in case of hypertensive patient. Why? Because in case of a heart failure patient, you're having an increased pressure inside the veins, and that's why the increased exchange of the fluid. But in case of a hypertensive patient, you're having the high pressure inside the arterioles and they're very thick walled. Okay, the exchange of fluid won't happen unless the fluid is present in the capillaries and unless the pressure is present in the capillaries and there is no arterioles after the capillaries present. Only the veins would be there without any musculature, right? And that's why you get the edema in case of heart failure. And that will be prevented by the lymph drainage. Is that okay?
Yes.
Very important concept. If the step one asks you, please remember this thing. Okay. And yeah, I think that would be everything on this page. Nothing's left. Then we need to study the cardiovascular pathology. And the first is the congenital diseases. Okay, you have two type of shunts for that. One is the left to right shunt, and second is the right to left shunt. Okay, when the shunt is left heart to right heart, the symptoms will develop very later in the life. Okay, because you are supplying the oxygenated blood from left heart to the right heart. So symptoms will be very much later when actually, when the shunt would be reversed from right side to left side, when the deoxygenated blood started mixing with the oxygenated blood. But in case of early shunts, which are the right to left shunts, the deoxygenated blood is mixing with the oxygenated blood of the left heart. And as a result, this blood would be supplying your organs and you will get the early cyanosis. Very important. Only in case of a right to left shunts, you will get the early cyanosis. Okay, and the patient will become symptomatic just after the birth, immediately. Okay, so whenever you encounter a patient who is having a cyanosis or a respiratory distress or something, any condition related to the heart, shortly after the birth, that means it must be a right to left shunt. Okay, if the patient is having symptoms similar to this right to left shunt after like 7 or 8 years of age, that means the patient must be having any left to right shunt initially. Okay, and the diseases which involve early right to left shunting, these include the truncus arteriosus, the patent truncus arteriosus, the transposition of the great vessels, the tricuspid atresia, the tetralogy of fallout, and the Epstein anomaly that you study later. Okay, and the total anomalous, this pulmonary venous return, very important, total anomalous pulmonary venous return. Okay, so the first thing is the patent truncus arteriosus. We have discussed this case already. You know that the neural cells are required for the formation of the aorticopulmonary septum, right? If the neural cells do not reach at their place, what's going to happen? No formation of the episeptum occur, and as a result, you will get a a single trunk, which is the truncus arteriosus. Okay, and because these cells are also responsible for the formation of membranous part of the intraventricular septa, right? So always with the patent truncus arteriosus, you will get the VSD defect. Okay, membranous VSD, ventricular septal defect. So very important, the patent truncus arteriosus because of the failure of the aorticopulmonary septum formation, and it is because of failure of the neuromuscular cells to reach and to arrive and form the episeptum, and as a result, both the aorticopulmonary septum is lost and the membranous intraventricular septum is lost. So you will get the patent truncus arteriosus as well as the accompanying VSD. And because all the blood from the left ventricle and the right ventricle will be mixing in the truncus arteriosus, so you will get the early cyanosis because of the high CO2 level, right? That's all. And because of this high CO2 level and low oxygen level, the respiration of the cells would be decreased. And the aerobic respiration of the cells would be decreased because of the low oxygen. So what would be the alternative way of the cells to respire if the oxygen is not available?
Lactic acid.
Exactly. So in all of these conditions, whenever you get the cyanosis, you will always get the lactic acidosis. Very important. In all of these conditions, you will get the lactic acidosis. Okay. Then comes the transposition of great vessels. In this scenario, the neuromuscular cells arrived at their location. Okay, but the twisting of the episepta does not occur. Okay, remember after the formation of episeptum, it need to be twisted so that the aorta would be, in the continuous, in the close connection with the left ventricle, and the pulmonary artery would be with the right ventricle. If the twisting do not happen, what's going to happen later on? The pulmonary artery would be originating from the left ventricle and the aorta would be originating from the right ventricle, right? So as a result, two different connection, two different circuits will form. Okay, two different circuits will form. All the blood from the aorta, it will be ultimately going to the systemic circulation, coming back into the right side of the heart in the right atrium. From the right atrium, it will go to the right ventricle, again to the aorta, again to the right atrium. So one connection, one circuit is there. The blood from the left ventricle will be going to the pulmonary artery. From the pulmonary artery, it will be going to the lungs. From the lungs, it would be going to the left atrium, and from the left atrium again to the left ventricle, again to the this pulmonary artery, again to the lungs, again the same circuit. So two different circuits will be formed. Okay, all the deoxygenated blood will be running in the systemic circulation, all the oxygenated blood will be running in the this pulmonary circulation. Okay, so it is kind of very incompatible with the life, right? So at any place the connection must be there, either the presence of VSD so that the mixing of blood could be occurred, okay, or the presence of a patent ductus arteriosus so that the mixing of the blood could occur here. Okay, you need one place to mix the blood, either the VSD should be there or the patent ductus arteriosus, right? And yeah, so you have to maintain the patent ductus arteriosus in these patients. And how can you maintain the PDA? If anyone remember?
Prostaglandin analog.
Exactly, alprostadil, if you guys remember. Okay, prostaglandin analogs, because these are the things which are responsible for the maintenance of PDA. Can anyone tell me, although the right side of the heart is connected to the systemic circulation, okay, please listen, the right side of the heart is connected to the systemic circulation, the pressure must be high in the circulation, right? And the left side of the heart is connected to the lungs, and lungs has so much reduced pressure. Then why not, why not the right to left shunt? If you maintain the PDA in these patients, then why not the right to left shunt? Why the left to right shunt only? You understood my question?
Could you please repeat?
See, your right side of the heart is totally connected to the systemic circulation, right? And left side of the heart is connected to the pulmonary circulation. Okay, and you know the lungs are there, which have a very low resistance. Okay, so that's why the pressure must be low in the circulation and pressure must be high in the circulation. Okay, maybe must be. Okay, if I maintain a PDA in this scenario, then the shunt must be from the aorta to the pulmonary arteries, right? After the birth, you guys know that after the birth, the shunt would be from the aorta to the pulmonary arteries, not from the pulmonary arteries to the aorta. But in this case, in case of transposition of great vessels, if I maintain the PDA, I will get a shunt from pulmonary artery to the aorta. Why is that so? That question must be arising in your mind, right? Why we get this kind of a shunt? Oh, is my voice is not audible? Please respond.
Yeah, there was a voice break.
Okay, should I repeat my question again?
Yes, repeat it.
Okay, see, you have the right side of the heart, this part, okay, which is connected to the systemic circulation, right? And you have the left side of the heart, which is connected to the pulmonary circulation, right? And you guys already studied that after the birth, if you maintain the PDA, the shunting will be from the aorta to the pulmonary artery, right? Before the birth, the shunting was from the pulmonary artery to the aorta. But after the birth, the shunting will be from the pulmonary artery to the shunting will be from the will be aorta from aorta to the pulmonary artery, right? But in this scenario, in case of a transposition of great vessels, I'm getting a shunt. If I maintain the PDA, then I will get a shunting of the blood from pulmonary artery to the aorta, not from aorta to the pulmonary artery. Why is that the case?
Because in this case, mainly the left ventricle is generating the high pressure in the pulmonary circulation. So in the pulmonary circulation, when there's high pressure due to the left ventricle, it will cause blood to flow from the pulmonary circulation.
And why this left ventricle generate high pressure?
Because it is having those thickened muscles.
Exactly. Good. You got the point. Okay, so by default, your left ventricle must be very much musculature. Okay, it must be having a very good musculature, right? Not the right ventricle. So you will get a very low systemic pressure and a very high pulmonary pressure. And that's why you get the shunt from pulmonary artery to the aorta. And of course, because of this high pressure, you will get the pulmonary hypertension, you will get the edema in the pulmonary circulation. And that's why I said it is very much incompatible with the life. Even after you maintain the PDA or the VSD, it is incompatible with the life. And soon you have to find a solution to reverse this thing. Okay, as you can see, without a surgical intervention, even if you maintain the PD or VSD, most infant will die within few months of the life. So a surgery must be performed on these patients. Okay.
Okay.
Any doubt?
No, no. Thank you.
Okay, then comes the tricuspid atresia. Remember what structure forms a tricuspid valve?
Endocardial questions.
Exactly. So because of the defect in the endocardial cushion, you will get the non-formation or the atresia of the tricuspid valve. As a result, the scenario could be like this. You have this complete right atrium, okay, the right ventricle, okay, the left auricle, which have this valve, and the left ventricle. Okay, left ventricle will be supplying the blood to the systemic circulation. Okay, and the right auricle will be receiving the blood from the systemic circulation. Okay, this is a right ventricle which must be supplying blood to the pulmonary circulation. Okay, and the this left auricle must be receiving blood from the pulmonary circulation. So blood can go from here to here, but at that point the blood must be stopped because there is no valve between the right auricle and the right ventricle. Okay, so a AST must be there plus a VSD must be there so that the blood can go from this right side to the left side. Okay, and again from the left side the blood can go from the VSD to this side. Okay, and then can reach to the pulmonary circulation. Or a shunt must be there, a PDA must be there, patent ductus arteriosus must be there, so that the mixing of the blood could be happen at this place. Okay, two things are must. The AST must be present, and one thing, either the VSD or the PDA must be there so that a mixing of the blood can be happen from systemic to the pulmonary circulation. And because if you maintain the PDA, like say, then you're not using your ventricles at all, right? That means the atresia of the atrophy of the ventricles will also happen in this scenario. Okay, so in case of the tricuspid atresia, you will get the hypoplasia of the right ventricle. The atrophy of the right ventricle would be there, and the ASD, VSD, or ASD with PDA must be there so that a mixing of blood can happen and the patient can live. Okay.
Okay.
And then comes a tetralogy of fallout. The tetralogy of fallout has happened because of the displacement of the infundibular septum, the septum which forms your aorticopulmonary septum and the VSD part, which is by the endocardial cushions and the neurotract cells. Now, what happened? Like generally, let's say, you have these ventricles, okay, and from the ventricles, you have this muscular interventricular septum, okay, and you have this truncus arteriosus initially, right? And just give me a second. Initially, it was more on the left side, okay, like that. Then what happens? The cells will arrive, these cells will arrive and then will form the episeptum. They will also form the membranous part of the VSD, right? Now, what happened if the displacement of this complete septum is happened to the right side? Okay, so now the aorta, which will be originating from the left ventricle, it must be shifted towards the right side, and as a result, it would be overlying the intraventricular septum, which is the muscular intraventricular septum. This is your aorta. Okay. Now, because this membranous septa is now shifted towards the right side, it would be gone. It won't be present. So you get a large VSD, okay, large membranous septum defect. The aorta will be overlying this defect. You will get the right-sided shifting of the pulmonary artery. Okay. So that is the tetralogy of fallout. So four things would be there. The tetralogy would be there. One thing is the pulmonary infundibular stenosis. You will get a pulmonary stenosis. Okay. Second thing, you will get the right ventricular hypertrophy. Okay. Third thing would be the overriding aorta, which would be overriding the ventricular septal defect. And you will get the ventricular septal defect. Okay. So stenosis, which as you can see here, this would be a pulmonary stenosis. Okay. Second thing would be the VSD. Third thing would be the this this aorta overlying this VSD. And fourth thing would be the hypertrophy of the right ventricle. Okay, these four things will happen in case of a tetralogy of fallout. And you will get a murmur, okay, of the pulmonary stenosis. You will get the murmur of the pulmonary stenosis. And where you can hear the murmur of the pulmonary stenosis?
Left upper sternal border.
Exactly, in the second intercostal space, for being more specific. Okay, and the symptoms of the tetralogy of fallout, whether the patient developed the symptom at birth or not, it would be totally dependent upon the right ventricular outflow tract obstruction. How much obstruction is there in this pulmonary stenosis, it will determine how much symptoms the patient will develop. If the stenosis is very much less, okay, then shunting can be happen from the left side to the right side, and the patient will remain asymptomatic till the later life. If this obstruction is increased, then what gonna happen? Because now the blood cannot go through this valve. What gonna happen? It will be shunted into the aorta, because the musculature is very much high in case of right ventricle. So instead of going through the pulmonary valve, it will go through the aorta, and the patient will get the cyanotic episodes. And whenever the patient get the cyanotic episodes, they will squat. And after the squatting, what gonna happen? The pressure inside the aorta will be increased. Okay, the pressure, the afterload will be increased, and as a result, the shunt could be reversed again from left to right. So whenever the patient get a TET spells or the cyanotic episodes, they will cause the squatting. And after the squatting, the systemic vascular resistance could be increased. Okay, so that the right to left shifting could be decreased, and that could improve the cyanosis. Okay, most important thing is it would be associated with the 22q11 syndrome, which is a microdeletion. Okay, remember the syndrome name?
DeGeorge.
DeGeorge syndrome. Yes, you will get it. Okay, and yeah, I think that's all. One more thing I'm forgetting to tell you. Just give me a second to remember that fact. Yeah, step one will also ask you one thing, that initially when the shunting was when the patient was normal, he was not having any TET spells, a murmur was there. Okay, a systolic murmur was there, and as soon as the patient got the cyanotic episodes, the murmur disappears. Okay, and now the step one will ask you what could be the concentration of the oxygen or the CO2 in the patient's blood now, something like that they will ask you. So please remember, the murmur will only disappear when the blood flowing through this valve will not be flowing through the valve, right? When the shunting would be there from the right side to left side, so only then the murmur could be disappeared, right? And whenever the murmur is disappeared, the patient will always get the cyanotic episodes, and as a result, you can see that the CO2 concentration in the blood will be increased, the saturation of the oxygen in the blood would be decreased. Okay, and the pressure on the left side of the heart could also be increased in this scenario, right? So they will ask you, when the murmur is disappeared, what gonna happen to the pressure changes, what gonna happen to the oxygen concentration changes. So remember, the murmur will only disappear when the blood will stop flowing through this valve. Okay, and instead flowing through this valve, the blood will go to the systemic circulation. Okay, and sometimes the PDA is also maintained in case of tetralogy of fallout. Step one will ask you what could be a symptomatic management other than this squatting. This will maintain the patient PDA, so that a mixing can happen in case of TET spells, right? And you will also get this boot-shaped heart, very important, because of the dilation of the right ventricle. Okay, you will get the boot-shaped heart, this thing you're getting. Okay, very important. Okay, any doubt on the tetralogy of fallout?
No. Thank you.
Please remember the infundibulum septum. Please remember all these 4 points, and the TET spells, what's going to happen to the squatting, and what's going to happen to the pulmonary stenosis murmur when the patient gets cyanotic episodes. Then comes the total anomalous pulmonary venous return, in which instead of supplying to the left atrium, the veins, they will enter into the superior vena cava. Very important. The pulmonary veins drain the blood into the superior vena cava instead of the right atrium. Okay, so again you will get the shunting from the left side, from the right side to the left side. Okay, so ASD or the atrial septal defect must be there, or the PDA must be there, so that the mixing of blood can happen and patient can live. This is a total anomalous for the pulmonary venous system. They will ask you where these arteries or the veins will be draining the blood, and this would be your superior vena cava and sometimes a coronary sinus, but not in the left auricle. Then comes the Epstein anomaly. In case of Epstein anomaly, it would be by the drug, which is the lithium. Okay, so lithium, very important. Okay, whenever the pregnant female takes a lithium, it can lead to the Epstein anomaly. It would be downward shifting of the tricuspid valve. And because of downward shifting of the tricuspid valve, you will having the atrialization of the right ventricle. Okay, it will be atrialization of the right ventricle. The right ventricle size would be decreased. It will become the size of an atria. So the atrialization of the right ventricle will be there. So you will get a tricuspid regurgitation. Okay, you will also get a formation of accessory conduction pathway, and that can lead to the Wolff-Parkinson-White syndrome. If you guys remember, accessory conduction pathway is formed in the Wolff-Parkinson-White syndrome. You will also get the right-sided heart failure because the ventricles are kind of very much shortened or a loss of size, and that's why you will get the loss of their function. So you will get the right-sided heart failure. Okay, and yeah, whole systolic murmur of the tricuspid regurgitation would be there. And where do you use the lithium in treatment of what disorder? Bipolar disorders. So they will ask you what could be the history of the patient or the on this pregnant female or the mother. It would be the bipolar disorder. Okay, so any doubt on this page?
No.
Okay, just give me a second. Okay. Then comes the left to right shunting. And because the left to right shunting is occurring, the oxygenated blood is mixing with the deoxygenated, not the deoxygenated is mixing with the oxygenated. Okay, so the concentration of the oxygen or the saturation of the oxygen in the systemic circulation is kind of normal. Okay, so the patient would be very asymptomatic at the time of birth. Only the murmur would be present. But after some time, when the shunt would be reversed from right to left, then the symptoms will be occur. So symptoms will always occur in the later lifeline. Okay, the most common one is the ventricular septal defect. The second is the ASD, and the last one is the PDA. Okay, very important. So first is the ventricular septal defect, and the most common defect in the VSD is the defect in the membranous part of the VSD, the membranous interventricular septum. Okay, it is the most common type. It could be happen by the endocardial cushion defect. It could be happen when the neuronuclear cells won't arrive there. Okay, ultimately what's going to happen, there would be a shunting of the blood. As you can see here, there would be a shunting of the blood from left side to the right side. Now, when the shunting of the blood is happening from left side to right side, the blood inside the left ventricle would be increased. As a result, the cardiac output of the right ventricle is also increased. So you will get the delayed S2, you will get the splitting of the S2. That is the first thing. Okay. Now, because the blood flow through the pulmonic valve is also increased, you will get the murmur from the this pulmonic area. Okay. First thing is the splitting of S2. Second thing is the murmur. Third thing, because now the blood in the pulmonary circulation is increased. Ultimately, in the later lifetime, what you can get is a pulmonary hypertension and the Eason-Menges syndrome. Because of the chronic left to right syndrome, this chronic left to right shunting, you will have the remodeling of the pulmonary vasculature. Okay, and when the remodeling of the pulmonary vasculature occurs, it can lead to the Eason-Menges syndrome. You will get the hypertrophy in the pulmonary veins, in the pulmonary arteries. You will get the hypertrophy of the right ventricle. And when the pressure inside the pulmonary system or the right side of the heart is increased so much that ultimately the reversal of the shunt will occur. okay, the pressure in the right side of the heart will be increased even more than the left side of the heart. And at that time, the shunt would be reversed from right to left. And at that time, the symptoms would occur. The patient will get the cyanosis, the patient will get this, the clubbing, the lactic acidosis, and everything. Okay. On the murmur, you will hear the harsh systolic murmur. Okay. And whenever you ask the patient to cause the increased hand grip, what's going to happen? The afterload will be increased. As a result, the shunting from left side to the right side would be increased, and that causes the increase in the murmur. Okay. And please remember, lower the size of this VSD, more is the murmur. Large is the size of VSD, less is the murmur. So in case of the, if you remember, in case of tetralogy of fallout, okay, you have the membranous VSD and you have a murmur. The murmur in case of tetralogy of fallout is not because of the VSD, because VSD is so much large in case of tetralogy of fallout. The murmur in the tetralogy of fallout is because of the pulmonary stenosis. Okay, remember the fact. Very important. So a harsh holosystolic murmur would be there. It would be heard in the tricuspid area, and the main thing that you will be able to differentiate it with the tricuspid regurgitation is by the by certain maneuvers. Okay, you will ask the patient to expire, you will ask the patient to inspire. If with the inspiration the murmur increased, that means it is a right-sided murmur, it must be tricuspid regurgitation. Okay, if after the inspiration murmur is decreased, that means it is a left-sided murmur or the VSD. Okay, with the hand grip maneuver, you can increase the flow, you can increase the murmur. Okay, very important. And the oxygen saturation in the right ventricle is increased. So if you measure the oxygen saturation in different chambers, you will have a normal oxygen saturation in the right auricle, but suddenly an increased oxygen saturation in the right ventricle. And the oxygen saturation of the left ventricle and the this left auricle would be absolutely normal. Okay, so they will ask you this, you will have an increased saturation of oxygen in the right ventricle only. Very important. And because the preload inside the right ventricle is increased, the cardiac output in the pulmonary vasculature is also increased. So you will get the pulmonary hypertension, and the same increased in the this increase in the cardiac output will be received by the left side of the heart. So you will get an increased preload in the left side of the heart. Very important. You will have an increased preload in the left auricle, so that the pressure inside the left auricle is increased. The pressure inside the left ventricle is also increased. Very important. You have an increased preload, you will have an increased pressure in the left auricle and the left ventricle. They will ask you this fact also. What's going to happen to the pressure in case of VSD? It would be increased. Okay. Any doubt on the VSD?
No.
Then comes the atrial septal defect. Okay, in case of atrial septal defect, you have two types. Okay, either it could be a defect in the septum primum, or it could be a defect in the septum secundum. Okay, most oftenly the defect is in the septum secundum. Okay, the primum defects are kind of very much rare, and they are generally associated with the Down syndrome. Whenever you get a patient with Down syndrome, they have a ASD, atrial septal defect, and it is because of the septum primum. Okay, in isolated cases of the ASD, it is most commonly the septum secundum defect. Okay, in case of ASD, because the intra-atrial septum is not there, you will have the shunting of blood from the from the left auricle to the right auricle, and as a result, the oxygen saturation in this right auricle is increased. The oxygen saturation in the right ventricle is also increased, but the saturation in the left side of the heart is absolutely normal. You will get a murmur because of this ASD. Okay, and because the flow of the blood from the pulmonary valve is also increased, you will get the fixed splitting of S2. First thing, you will get the fixed splitting of the S2, which means the splitting would be there in in the inspiration and as well as in the expiration. Okay, and also you will get a murmur of the pulmonary stenosis type, because it is not the stenosis actually, but because the flow of the blood is increased through the valve, you will get the murmur like the pulmonary stenosis. Okay, and sometimes what happens if a thrombus is formed inside the veins and it becomes the embolus. Okay, embolus can reach to the right auricle, and in general scenario, if there is no ASD, what's going to happen to the embolus? It will go to the right auricle. From right auricle, it can go to the right ventricle. From right ventricle, it can go to the lungs. Okay, and you will get a pulmonary infarction, right? But in case of ASD, this embolus can reach to the right auricle, and from the right auricle, sometimes the embolus can reach to the left auricle also. Okay, from the left auricle, it can reach to the left ventricle and then to the systemic circulation. So you can get a systemic emboli like stroke and like the renal infarction or other areas of infarction. So whenever you encounter a patient having a history of this venous thrombosis, and now he is having a systemic emboli, if he is having a symptom of strokes or like renal infarction, that means it could be a case of atrial septal defect. Okay, and please remember, the patent foramen ovale is more common than the ASD. So if they do not mention any specific cause, you will always consider the patent foramen ovale. And the difference between the patent foramen ovale and the ASD is, in case of ASD, the formation of septum is not occurring in the first place. Okay. In case of foramen ovale, a patent foramen ovale, the fusion of two septums are not occurring. Okay. You will get a left to right shunting in case of ASD, but in case of a patent foramen ovale, only right to left shunting is possible because of a one-way valve. Okay. Very much important to know that. You will get an increased saturation in the right auricle, right ventricle, and the pulmonary artery. You will get a paradoxical emboli, which will become the systemic emboli. Okay, it can be associated with the Down syndrome. It is most commonly the ostium primum defect or the septum primum defect. Okay, a continuous murmur would be there sometimes. Why? Because the pressure in the left auricle is always more than the right auricle, right? Both in the systole and as well as in the diastole. So you can either get a continuous murmur, okay, or sometimes you can get a systolic murmur at the pulmonic area because of the pulmonary stenosis type, because of an increased flow through the pulmonary valve. Okay, and you will get the splitting of a wide splitting of the S2. Fixed splitting of the S2, not the wide, sorry. Fixed splitting of the S2. Yeah. Any doubt on the ASD?
Could you please explain me the difference between ASD and patent foramen ovale once again, and like the direction of flow?
See, like we've already discussed about this. In case of a patent foramen ovale, you have a one-way valve. Remember? Like, let me draw
Left
this.
to right.
Yeah, I remember that.
You have this complete auricles. Okay, you have this septum primum. Okay, and you have this septum secundum, right? Like this. And now the blood can only flow from this. This is the right side. This is the left side. The blood can only flow from the right side to the left side, right? Not from the left side to right side. Because if the blood try to flow from left to right, the valve will close, right? So in case of an atrial septal defect, you can only have a shunting of blood from right to left, not from left to right. But in case of a ASD, because you are not having this the formation of the septums in the first place, you can have a left to right shunting, and it must be continuous, because after the birth, the pressure inside the left side of the heart is always more than the right side. Okay, so you will get the shunting in the left to right. But in case of patent foramen ovale, only the right to left shunting is there. Okay.
Yeah, okay. I have a doubt. Like when I was studying from BNB, that guy that guy was explaining that we can have paradoxical emboli even from right to left side in a case of patent foramen ovale. So how is it possible? Like if there's a patent foramen ovale, how can the clot go from the right side to the left side?
That's exactly what we have discussed, Api. I've told you shunting of the blood can only happen from right to left. So if an embolus is there in the right side of the heart, it can easily reach to the left side of the heart, right?
Okay, I got it. Okay.
Yeah.
Thank you.
And remember, in case of ASD, you have a defect in the formation of septum. In case of this patent foramen ovale, you have a defect in the fusion of these two septums. Okay, this is a very important thing. Let me clear the annotations. Yes. Okay, then comes yeah. Someone is asking Ocean. Any doubt? Okay. Oh, now comes the patent ductus arteriosus. Okay, you have a ductus arteriosus in the fetal life. This ductus arteriosus actually causes shunting of the blood from the pulmonary artery to the aorta. But after the birth, because of the pressure in the systemic circulation is increased and the pressure in this pulmonary section is decreased. In that time, you have a reversal of the shunt. Okay, the shunt will be from the aorta, from the pulmonary artery to the aorta, right? And like we have discussed, after 3 or 4 days of the life, this PDA must be closed to prevent the shunting. Okay, but if it is not closed, then it is known as the patent ductus arteriosus. So in this case, you're having a shunting from the aorta to the pulmonary artery. So anyone remember the location of this, the PDA?
Is
After which artery, which branch?
Subclavian artery.
Left subclavian artery. Okay, this is present after the left subclavian. This is a left subclavian artery. Okay, and this shunt is present after it. Very much important. They will ask you the location. Very important. It is present after the subclavian artery, and because it is present after the subclavian artery, the mixing of blood will only happen after it, right? So in case of a Eisenmenger syndrome, when the reversal of the shunt happens, the mixing of the blood from the from the pulmonary to the aorta, it will happen only after the subclavian artery, right? So you will only get the cyanosis in the lower part of the body, not in the upper part. Okay, very important. You will get the cyanosis only in the lower part of the body, not in the upper part. Up to the hands, the patient is absolutely normal, but below the hands, the patient will have the cyanosis, and this is known as the differential cyanosis. Okay, you will have the cyanosis in the lower extremities only. Okay, and because the pressure in the systemic circulation is always higher than the pulmonary circulation, both in the systole and as well as in the diastole, so you will have a continuous machine-like murmur. Okay, and we have already discussed this thing that the prostaglandins are responsible for the maintenance of the PDA. Okay, so one of the treatment of the PDA is to give the patient NSAIDs which inhibit the prostaglandin synthesis, and to maintain the PDA we need to give the patient prostaglandin even, and the drug name is the alprostadin. Okay, the patient will also have a bounding femoral pulses and the palmar pulses. Okay, it is one of an important symptom of the disease, bounding femoral and the palmar pulses. Okay, and if step 1 asks you about the preload and the cardiac output and the oxygen saturation, so the saturation of oxygen is increased only in the pulmonary artery. All the chambers, they have a normal saturation, but suddenly the saturation will be increased in the pulmonary artery because of the mixing of this blood. And because the blood is mixing from the aorta to the pulmonary artery, the flow of the blood to the artery is increased, and as a result, the preload of this left side of the heart is also increased. Very important. The preload is increased. So you will have a high left ventricular cardiac output. Okay, very important. You have an increased venous return, you have an increased cardiac output, you have an increased preload. Okay, and you have an increased saturation in the pulmonary artery. You will have a differential cyanosis also. Okay, very important to note that. And yeah, that would be all about the patent ductus arteriosus. One more thing, if we go back to the previous page, see, just give me a second. What gonna happen if I maintain the PDA in case of tetralogy of fallout, or the let's say the case of transposition of great vessels? What would happen if I make a PDA, a patent ductus arteriosus, if I maintain it? Then what gonna happen to my cyanosis? In which part of the body I got the cyanosis, and in which part of the body I do not get the cyanosis?
Cyanosis in the superior extremity and normal in the lower extremity.
Exactly. So please remember, if the step 1 will give you a history of patient who is having cyanosis in the upper extremities, that means it must be a case of a right to left shunting. Okay, a case of transposition of great vessels could be there. A case of tetralogy of fallout could be there. Okay, and when you are having a cyanosis in the lower extremities and the normal upper extremities, that means it must be a case of patent ductus arteriosus. Okay, so please remember the case of differential cyanosis, whether it is having a cyanosis in the upper extremities or in the cyanosis of lower extremities. Okay, very important to note that. And yeah, I think that's all about it. Yes. Then one more case, which is the correctation of the aorta. As the name suggests, the correctation of the aorta occurs. It will become kind of very much stenosis, so no blood can be flow through this part of the aorta. It generally happens after the subclavian artery. Very important. It generally happens after the subclavian artery. So now what's gonna happen? You have the vessels which are supplying the after these subclavian vessels, you have the blood vessels to the thorax, right? So all these thorax vessels, let me annotate it. After subclavian vessels, what's going to happen? All new vessels will be formed. The thoracic vessels, they will be supplying blood to the aorta. Okay, instead of moving the blood from here to here, what's going to happen? This is blocked completely. So now the blood will travel through these vessels. Okay, the thoracic vessels, and from thoracic vessels, it will reach to the aorta again. Okay, so and all these vessels are present in the ribs. Okay, all these vessels are present in the ribs. So because the flow of the blood is increased through these vessels, the dilation of these vessels will occur. Okay, the dilation of these vessels will occur, and you will get the notching of the rib on the chest x-ray. Because of this increased circulation, you will get the notching of the ribs. The intercostal arteries, the thoracic arteries are the intercostal arteries through which the collateral circulation will be provided to the aorta, and that's why you will get the notching of the chest x-ray. Very important. Okay. It is generally seen in case of bicuspid aortic valve. So remember the three associations with the bicuspid aortic valve. What does this bicuspid aortic valve can lead to? The three complications. If anyone remember. Yeah.
Aortic stenosis.
Aortic. Yeah. One is stenosis. Second. One is the aortic stenosis. Second, aortic regurgitation, right? And third is the correction of aorta. Okay, so three things. One is the stenosis, second is the regurgitation, and third is the correction of aorta. These three things can be happen with the bicuspid aortic valve. Okay, it is also associated with the Turner syndrome. Very important. It is also associated with the Turner syndrome, and because of this correction, you will have an increased blood flow in the upper extremities and a low blood flow in the lower extremities. So you will get a very high upper extremities pressure and a very low lower extremities pressure. And because the blood supply to the lower extremities or the lower organs is now lost, what's going to happen when the patient try to exercise? He will get the claudication. He will get the pain, right? Because the blood supply to the lower extremities is now lost. Whenever the patient try to exercise, okay, there would be a supply demand mismatch, and that can lead to the pain in the lower extremities. Okay, you will have a weak pulses, you will have the hypotension, you will have the pain in the lower extremities, and a very high blood pressure in the upper extremities would be there. Okay, notching of the ribs would be there. Okay, very important. And a very high risk of cerebral aneurysms. Very important. You will get the Barry aneurysms with the correction of aorta. A very important cause. Step one will ask you, they will give you a history of a patient having the Barry aneurysms, and they can ask you what could be the risk factor associated with it. And one of them is the correction of aorta. Okay, very important. Okay, now because and second important thing, just give me a second. Yeah, now, before the correction, because the pressure is now very much increased, you can have a damage of the arteries, right? And when the arteries get damaged, this can lead to the the damage of the valves can occur, not the arteries. The damage of the valves can occur, and that can lead to the endocarditis. Whenever you have a damaged valves, that can lead to the subacute endocarditis. If you guys remember, if you have a damaged valves, it can lead to the subacute endocarditis. Very important. And below the pressure, and below this correction, the pressure is so much low. Okay, you will have the ischemia. Okay, and you will have the endarteritis also. Because the blood flow is now very much decreased, the bacteria can easily colonize this part of the artery. It can lead to the endarteritis. So before the correction, you will have the endocarditis. After the correction, you can have the endarteritis. And because of the formation of this collateral supplies Okay, because of the formation of this collateral circulation, what's going to happen? The blood will be flowing continuously through these vessels, both in the systole and as well as in the diastole. And that's why you get a continuous murmur in case of the coarctation of aorta. Very important. You will also get the continuous murmur in case of coarctation of aorta. So how you can differentiate between the coarctation of the aorta and the PDA? If anyone can tell me.
Height of the murmur.
Height of the murmur.
No. I mean the site of the murmur.
Site of the murmur. Yes. Where would you hear the PDA?
Left infraclavicular region.
Okay. And where would you hear the coarctation of aorta murmur?
In front, in the chest, and at the upper right side.
Not in the front. You cannot hear that in the front. You will hear that in the back, just lateral to your spine. Very important, the location of the murmur. If you want to hear the murmur, you need to place this stat on the lateral of your spines. Very important. Okay, so they will give you the location. Yes, okay.
Interstitial region, right?
Yes, exactly. The parasternal region. Oh, sorry. The paraspinal area. Okay, very important. Then the location of this murmur. So you can differentiate it by the locations. Very important. Okay, then comes the Eastern-Menzel syndrome. So with a chronic left to right sided the shunting of the blood, what's gonna happen? The pressure inside the right side of the heart is increased, and as a result, the pressure in the pulmonary vasculature is increased. Now, because of this increased pressure, would be the remodeling of the pulmonary vasculature occur. Okay, you will get the pulmonary hypertension, and because of the hypertension, you will get the hypertrophy of the pulmonary vasculatures. Okay, and because of this hypertrophy, please note that this hypertrophy is irreversible. Okay, very important, this hypertrophy is irreversible. If the hypertrophy occur in the heart, like in case of right ventricular hypertrophy, it could be reversible when the symptoms are over, when the disease is over. But you will get the irreversible damage to the pulmonary vasculature, and that is the feared complication of all these left to right shunt. If the step one asks you what would be the feared complication of these left to right shunt, it won't be the right ventricular hypertrophy, but it would be the remodeling of the pulmonary vasculature, because it is irreversible. You will get the pulmonary hypertension, and because of the pulmonary hypertension, the BP will become so rise, the pressure becomes so rise that it would become even more than the left-sided heart pressure. And so that the reversal of the shunt will occur. Now the deoxygenated blood in the right side will be mixing with the oxygenated blood in the left side. And as a result, the cyanotic episodes will occur. And you will also get the clubbing. Remember, I told you in the general pathology section that whenever you have a remodeling of the pulmonary vasculature, like with any kind of tumor, like in case of Eastern-Menzel syndrome, like with any disease, like a AV shunt could be there, okay, a fistula could be there. Whenever you have a pathological remodeling of the pulmonary vasculature, you can have a cyanosis. Anyone remember why? This clubbing, why? We have discussed that in the general pathology section already.
Due to migration of megakaryocytes.
Exactly. Yes. The megakaryocytes will bypass the lungs. They will go to your fingertips, and there they can release the cytokines and the growth factors that can cause something known as the it is starting from O.
Hypoxic pulmonary osteoarthropathy.
Exactly, osteoarthropathy it will cause. Okay, very important. And because you're having this hypoxia, what's going to happen to the RBC levels? They will rise. Okay, so you will get the polycythemia, you will get the cyanosis, you will get the clubbing, and what's going to happen to lactic acid level? They will rise. Lactic acidosis, cyanosis, clubbing, polycythemia, that you will always see in these patients, right? And the age of onset is always varying. Very important. And if you hear a continuous murmur in case of a 4 or 5 days old baby, it would be absolutely normal. You cannot say the patient is having a patent tetanus arteriosus, right? It would be physiological normal completely. Okay, so any doubt on this page?
Could you please explain the femoral bounding pulses in PDA?
See, you have a mixing of the blood. So some of the blood is kind of going to the pulmonary circulation, not into the systemic circulation. So you can have a fall of the pressure. And then when heart again constrict, when the heart again contract, you will have a very raised pressure. Okay. And because the shunting is after the, the subclavian artery. So if you are, you are going to have this high and low pressure in the femoral areas, very much high. So that's why you can get the bounding femoral pulses
And
because of rapid rise and rapid fall in the pressures.
okay. And what are Palmer pulses?
Palm same as that, palm is for the hands.
Okay. All right. Thank you.
Okay, so that's all, everything on this page. Remember the harsh murmur. Okay, the murmur just like the pulmonary stenosis in case of AST because of the high blood flow. Remember the harsh, the machine-like murmur in case of PDA. The same murmur could be heard in the correlation of aorta, but on a different location. Okay, remember the Eastern syndrome. Remember the difference between the patent foramen ovale and the AST. Okay, and yeah. Then comes the congenital defects. If you take the alcohol, you can have the VSD, PDA, AST, or the tetralogy of fallout. Okay, so you can have any kind of septal defect. Okay, and the tetralogy of fallout for the alcohol exposure. For the rubella, very important, you can have a patent ductus arteriosus. Remember the three things that will happen with the congenital rubella. We have studied in the torch infection.
Yeah, ocular defects and heart defects and ear defects.
Exactly. What is the ocular defect?
Cataract.
Exactly, cataracts. Then comes a Down syndrome. In the Down syndrome, you have a special type of defect, which is the endocardial cushion defect. Very important. In case of Down syndrome, you are having a endocardial cushion defect. And remember, the endocardial cushions are responsible for the formation of valves. Okay, the tricuspid valve, the mitral valve, the aortic valve, right? And the septums also, the VSD. Okay, so in case of Down syndrome, you will get the ASD, you will get the VSD, you will get a single AV valve. Very important. Like in a normal heart, if I draw a normal heart, you have the two valves, right? One is the tricuspid valve and second is the mitral valve. But in case of a Down syndrome patient, you're gonna have a single valve. Okay, this is the right and the left, and you're kind of like that. Just a second. You have VSD also, right? Like that. This is the case of a patient with Down syndrome. Okay, a single AV valve would be there, not the two. VSD would be there, ASD would be there. Okay, and this is known as the endocardial cushion defect, which is seen with the Down syndrome. Okay, a special case. Very important to note. Single AV valve would be seen on the chest imagings, okay, of the echocardiogram of the heart. Okay, VSD would be present, ASD would be present. This is Down syndrome and the endocardial cushion defect. Okay. Then comes the diabetes. It can lead to a transposition of very important. This part is important. Forget the VSD. Transposition of great vessels can happen in case of diabetes, a very important complication. For the Marfan syndrome, we have discussed, you can have the dissection of the aorta, you can have the aortic regurgitation, you can have a mitral valve prolapse, and you can have aneurysms because of the cystic medial degeneration. You can have the aneurysms. For the lithium, you can have the Epstein anomaly. With the Turner syndrome, you can have the bicuspid aortic valve and the correlation of aorta. Okay. And then comes the Williams syndrome. Remember, in case of Williams syndrome, you can have a supravalvular aortic stenosis, which mimics the aortic stenosis, but not a true aortic stenosis because the valves are absolutely normal. Which chromosome defect is the Williams syndrome?
7.
Exactly. Okay, remember it. And the Pitou syndrome?
13.
Which one?
13. 1, 3.
13. Yes. And the Craduchet syndrome?
5.
5. Okay. Do not forget these defects. Then comes the 10TQ11 microdeletion syndromes, which includes a truncus arteriosus, can cause a truncus arteriosus. And importantly, they can cause the tetralogy of fallout. Most commonly, tetralogy of fallout. and less commonly truncus arteriosus. Okay, that's all the defects. We have already discussed every one of them. Then comes the case of hypertension. Hypertension, you call a patient whenever the BP rise above the 130, the systolic BP rise above the 130, and the diastolic BP rise above the 80 or 90. Okay, so whenever you got a patient having a 130 or 80, more than 130 or 80, you will call it a hypertension. Okay, what are the risk factors for the hypertension? The most important one are the age, diabetes, obesity, cigarette smoking, very important, and the family history. Physical inactivity can lead to the hypertension. Okay, excess salt intake can lead to an increased volume of blood inside you, that can lead to the hypertension. Okay, and they are mostly the cause of primary hypertension. For the secondary hypertension, it is always it is always due to a secondary condition. A primary condition can lead to a secondary condition, which is the hypertension. Okay, and most oftenly it would be a blockage in the renal vessels. Whenever you have a blockage in the renal vessels, the renal blood flow is decreased, and because of a decrease in the renal blood flow, you have a loss of GFR that can lead to the activation of RAS, and RAS can lead to the sodium and this water reabsorption increased, and that can lead to the hypertension. Okay, so the secondary hypertension is mostly because of the renal or the renovascular diseases. Okay, and the primary hypertension is kind of idiopathic type. It do not have any specific cause, but it do have the risk factors like age, smoking, obesity, diabetes, family history, salt intake, physical inactivity. Okay, and in case of a primary hypertension, you have an increased cardiac output or the increased TPR. Okay, you have an increased cardiac output or the increased total peripheral resistance. Okay, and for the 10% of cases, they're mostly secondary to some kind of a renal diseases or the renovascular diseases. Like in case of a fibromuscular dysplasia, which is especially seen in the women's only, women of the reproductive age, they can have the fibromuscular dysplasia. As the name suggests, they have a fibrous web formation in the arteries. Okay, we will discuss that later in the renal section. Okay, you will have the stenosis in some areas, webs formation in some areas, and you can have a hypertension. The secondary hypertension can also happen when you develop an atherosclerotic plaque in the renal vasculature. Okay, and that can lead to the renal artery stenosis. That can lead to the primary and this can lead to the secondary hypertension. Okay, it can also be happen after the primary hyperaldosteronism. Remember, if you have a hyperaldosteronism, that can also lead to the hypertension. Okay, you can also have it in sometimes in case of a hyperthyroidism. Okay, very important. So these are the causes, specific causes for the secondary hypertension. But most of the hypertension are kind of essential and they are primary. They do not have any specific cause. Okay. Now, hypertension can include two things. One is the hypertensive urgency, and second is the hypertensive emergency. You will call it a hypertensive urgency when you have a very severe hypertension, which is more than 180 by 120. When you have a systolic blood pressure of 180 and the diastolic of 120, you will call it a hypertensive urgency. If you do not have any end organ damage, if you do not have any symptom, if the patient is just having a high BP, but no symptom, okay, nothing, just a high BP, and the patient is asymptomatic, you will call it a hypertensive urgency. If the patient is having a very severe hypertension of 180 by 120, and with the evidence of a symptom, any kind of symptom, or any acute end organ damage, the symptom could be a blurring of the vision. Okay, the symptom could be a headache. The symptom could be a chest pain. The symptom could be a flank pain. The symptom could be of oligouria. Okay, symptom could be of aortic dissection, like a chest pain we have discussed. Okay, symptom could be anything. So whenever you encounter a patient having a very severe hypertension along with one symptom, at least one symptom, that means the patient is having a hypertensive emergency. Otherwise, you will call it a hypertensive urgency. Okay. In case of hypertensive emergency, you're going to have something known as the fibrinoid necrosis. If you remember from the pathology section, general pathology, you're going to have the fibrinoid necrosis. Okay, you will have the formation, you have the deposition of these proteins inside the blood vessels, and this pinkish material, the thickness of the vessels would be seen on the microscopy. Okay, so the fibrinoid necrosis. And second thing is the hyperplastic arteriolosclerosis. Two things gonna happen in case of hypertensive emergency. One is the fibrinoid necrosis, okay, and second thing, it would be the hyperplastic arteriolosclerosis, which is seen like this onion skinning, as you can see on the diagram on this histology section here. You're having this onion skinning, okay. This is a hyperplastic arteriolosclerosis, which is seen in the hypertensive emergency. Okay, you will have the proliferation of the smooth muscles, okay, so that the damage of the blood vessels could be prevented. And because of the proliferation of the smooth muscles, you're going to have this onion skin appearance. Okay, it would be in the arterioles of the kidney, retina, heart, lungs, liver, brain, anywhere, right? Whenever you do the biopsy of the patient of these organs, you can find the arteries which are having this arteriolosclerosis. And if not the arteriolosclerosis, the patient can also have the fibrinoid necrosis. Okay. So in case of a hypertensive emergency, you have the end organ damage, like in case of CVS, you can have the angina symptom, chest pain, myocardial infarction, again the chest pain, aortic dissection, again the chest pain. For the CNS, you can have the retinal hemorrhage. Okay, you can have the this papillary edema. The papillary edema. Okay, you have the encephalopathy. Stroke can happen. Okay, the blood vessels inside your brain can rupture. For the renal, you can have the nephrosclerosis. Okay, or the thickening of the vessels supplying the kidneys. Okay, in the lungs, you can have the pulmonary edema because of this high blood pressure. Okay, in the retina, you can have the papillary edema, flame-shaped hemorrhages. Very important, the flame-shaped hemorrhage you will see on the fundoscopy. We will see that later in the ophthalmology section. Don't worry about that. And important thing, isolated systolic hypertension, which is only seen in case of old age patients because of the this arterial stiffening. Okay, very important. And these are the complications, the coronary artery diseases. Okay, the left ventricular hypertrophy. It can also lead to the heart failure because of this increased afterload and the hypertrophy. You can have a heart failure. Okay, atrial fibrillation can occur. Remember, I told you whenever a pathological remodeling of the heart happen, it can lead to the atrial fibrillation. Okay, it can lead to the aortic dissection, aneurysm formation, stroke. The chronic kidney disease can happen. Retinopathy can happen. These are the complications. Okay. So, any more doubt on the hypertension?
No.
Okay. And one important thing that I want to tell you, because of the hypertension, everywhere in the body, you're going to have this arteriolosclerosis, right? And because of the arteriolosclerosis, you're having a thickness of the blood vessels. And when the blood vessels thickened, okay, the lumen size in the blood vessels is decreased. And as a result, the blood supply to the different organs is decreased. Very important. Whenever you have a hypertension, okay, the one of the feared thing is that the blood supply to the different organs is now going to decrease because of this arteriolosclerosis. Okay, so you will have a renal atrophy. Okay, it is not the infarction because infarction occurs very suddenly whenever a blockage is there. But in case of a hypertension, slowly the blood supply to the kidneys is decreased. And they will ask you this case of nephrosclerosis. What findings you will see in the nephrosclerosis? First thing, it do not happen in the emergency. It happen in the urgency only. Okay, where you have this arteriolosclerosis, and as a result, the blood supply to the kidney is lost. You will have okay, and when the blood supply to the kidney is lost, what's gonna happen? You will have the atrophy of the kidney. You will have the collagen deposition in the kidney. Okay, the cell size of the kidney is decreased. Different renal cells will be decreased. The crowding of the glomeruli would be there. Okay, and the parenchyma of the kidney is reduced. That's all the finding you will see in the nephrosclerosis. Very important. Okay, and yeah. So I will ask you the case of this hypertensive nephrosclerosis. Okay, due to the renal vasculature damage, you will have the intimal thickening. You will have the lumen narrowing. Okay, for the glomeruli, you will have the glomerulosclerosis. You have the crowding of the glomeruli because of the renal atrophy. For the interstitium, you will have the fibrosis. You will have the deposition of this collagen. Okay, so please remember, very important, the findings in the hypertensive nephrosclerosis. Why this happening? Because of the hypertrophy of the renal vasculatures, so that the blood supply to the kidney could be lost. So any doubt up to this point?
No.
Okay. Then we need to know about the hyperlipidemia sign. We have discussed in the biochemistry section about the different disorders that can lead to the hyperlipidemia. If anyone remember the name,
Please
four
repeat.
disorders we have discussed. Four disorders we have discussed in the biochemistry section about the hyperlipidemia, the familial hyperlipidemia. Remember?
Yeah, type 1 to 4.
And the name them.
Type 1 is mm,
Hyperchylomicronemia.
yeah, and type 3 was this beta lipoproteinemia.
And type 4, hypertriglyceridemia, right? Okay. So in all these scenarios, in four conditions we have discussed now, okay, what's gonna happen? You're gonna have the hyperlipidemias. And remember, I told you the symptom of all these hyperlipidemias. Like in case of a hyperchylomicronemia, you're gonna have something known as the eruptive xanthomas. Okay, where you have a very the pruritus over the palms. You have the redness over the surrounding area, and you have this yellowish deposits all over the palm. Remember?
Yeah.
Okay, so now we're going to discuss all these hyperlipidemia signs. Okay. So you have the familial hyperlipidemia, you have the cholestatic conditions, okay, just like the primary biliary cirrhosis. Okay, these things can lead to the hyperlipidemias. Okay, the first sign is the xanthoma. And let me just stop it for now, and I will open a slide so that you can have a better understanding of the hyperlipidemias. Give me a second. For the diagram, you can refer to the first aid. Okay, and for different xanthomas, see it here. Okay. Okay, so first thing is the eruptive xanthoma. Okay, which is seen in the hyperchylomicronemia. It is due to the increase in the triglyceride levels. Okay, and what symptoms you will see? You will see the yellow papules with the erythematous borders. So in the center, there would be a yellow papule, a raised lesion, and surrounding the red lesion is the reddish area. Okay, the erythematous border, and it is very pruritic. Okay, very important. These are the eruptive xanthomas seen in the hyperchylomicronemia. Why? Because of this high triglyceride level. Second are the tendon xanthomas. Okay, and the tendon xanthomas, they are most commonly seen on the Achilles tendon. You will have a bump, a subcutaneous bump on the Achilles tendon. If you do the biopsy of this bump, you will see the fat cells there, a very fat rich cells. Okay, macrophages will be laden with the fat. You will see on these bumps. This is the histology. It is because of the high cholesterol level. Why? Because of the high cholesterol level, generally seen in the hypercholesterolemia. Very important. The tendon xanthoma is seen in the hypercholesterolemia. Okay. And remember the cause of the hypercholesterolemia, the LDL receptor deficiency and the B100 deficiency. How you can differentiate between the two deficiencies? If anyone remember from the sections, how you can differentiate between the LDL receptor deficiency and the B100 deficiency? Remember the VLDLs and the LDL level, they will be raised in case of B100 deficiency. Okay. But the LDL only, they will be raised in case of LDL receptor deficiency. Okay. Please remember this fact. Both the VLDL and LDL will be raised in B100. Only LDL will be raised in case of LDL receptor deficiency. Okay. Then comes the Palmer xanthomas. Okay. These xanthomas, the yellowish deposits will be seen on the palms of the hand. Okay. These are generally seen in the primary biliary sclerosis. And the dis-beta lipoproteinemia, very important, it is seen in the primary biliary sclerosis and in the dis-beta lipoproteinemia. Then comes the corneal arcus. Refer to the first aid, and they have this figure D, which is showing this the corneal arcus in the eye. At the periphery, you can see this whitish deposits in a form of ring. These are the corneal arcus. Okay, and it is in the hypercholesterolemia. Okay, so for the hypercholesterolemia, you can have the tendon xanthoma, you can have the corneal arcus, and the third thing is the xanthelasma. Very important. Third thing is a xanthelasma, which is a yellowish plaque on the medial side of the eyelid. See the first aid, the figure B. Okay, these are the xanthelasmas, which are the yellowish deposits on the medial side of the eye. It is also seen in case of hypercholesterolemia. Okay, so for the hypercholesterolemia, you're gonna have the this xanthelasmas. You can have the corneal arcus. You can have the tendinous xanthomas. Okay, for the diabetic lipoproteinemia, you can have the palmar xanthomas. For the primary biliary sclerosis, you can have the palmar xanthomas. Okay, for the eruptive xanthoma, you need to have a high triglyceride level that could be seen in the hyperchylomicronemia. Okay, so that's all about the hyperlipidemia sign, very important, and they will always appear as a subcutaneous bumps. Okay, any doubt on that?
No doubt.
They will give you the picture of the patient. They will ask you what could be the case here. They can ask you the histology. They can ask you the cause of this disease. Okay, they will give you the location of these xanthomas, and they will ask you the location could be associated with which of the following disease. Okay, so please remember the location and the disease name. Then comes the this arteriolosclerosis, which is the hardening of the arteries. Okay, with the wall thickening and the loss of elasticity. Okay, remember the arteries has a property of elasticity and the veins has a property of compliance, right? So in case of arteriosclerosis, because of this hardening, you're going to have the loss of elasticity. Okay, two types are there. One is the hyaline and second is the hyperplastic. Hyaline is seen in case of essential hypertension. Whenever you have a hypertension more than 130 by 90, you're going to have this hyaline arteriosclerosis because of the deposition of the proteins in the endothelial layer. Very important. Because of this high blood pressure, the endothelial layer would be damaged. Okay, sometimes. And after damage of this layer in the subendothelial layer, which is a space between the tunica intima and the tunica media, the deposition of the proteins would happen, as you can see in the histology. And because of the deposits of these proteins inside the vessels, inside the walls of the vessels, you're going to have the hyaline arteriosclerosis. Okay, and yeah, it is also seen in case of diabetes mellitus. Remember, in case of a diabetes mellitus, you can have an ongoing inflammation, and by this inflammation, the endothelial damage will happen. Okay, and because of this high glucose level, the non-enzymatic this glycosylation will occur. Okay, the proteins will become glycosylated and they will deposit in the walls that can cause the hyaline arteriosclerosis. Okay, and you have a regular thickening of the artery in this case. Very important. You have a regular thickening of the artery from in this area, in the upper, in the lower part, in the right and the left part. From everywhere, the artery is kind of uniformly thickened. Very important to note. Okay. Then comes the hyperplastic arteriosclerosis, which is seen in the hypertensive emergency. Okay, where you have the proliferation of the smooth muscles, and that can lead to the onion skinning, as you can see, because of the concentric layer. Okay, the proliferation of the smooth muscles occur in case of in this hyperplastic arteriosclerosis. It would be happen in the concentric layers. Okay, and that can cause the this hyperplastic arteriosclerosis. Okay, and this hyperplastic arteriosclerosis, it is kind of non-uniform type. Unlike the hyaline, it is kind of non-uniform. Okay, at some part it is thickened, at some part it is kind of thin. Okay, irregular fashion, and this can lead to the macroangiopathic hemolytic anemia. Okay, whenever the RBCs pass through this part of the arteries, they will be lysed. Okay, and they will become the cystocytes, if you guys remember the cystocytes. Okay, this is the macroangiopathic hemolytic anemia, which is seen in the severe hypertension, in the hypertensive emergency. Okay, so step 1 can give you a history of the patient where the PBS is showing the macroangiopathic hemolytic anemia. They can ask you what could be the cause of it. So multiple causes are there. For the further history, you can determine whether it is a cause of hyperplastic arteriosclerosis. Okay, very important. Then comes the Mockenberg sclerosis. In this scenario, you have a deposition of calcium in the vessels. It is asymptomatic condition, not significantly, not very clinically significant condition. Okay, nothing. It just on the X-ray, you can see the calcifications of the arteries. Okay, and this could be seen in case of a chronic kidney disease. Remember, in chronic kidney disease, you're going to have a very high calcium levels. Okay, and the calcium will be combined to this potassium, okay, to form a complex that will be deposited on different tissues. One of them are the arteries, okay, and that can lead to the Mockenberg sclerosis. Okay, and yeah, it does not affect anything. Okay, it does not cause the obstruction of blood flow, nothing. Okay, it is clinically insignificant. Okay, very important. Any doubt on this page?
No, no.
Then come the atherosclerosis, which is a formation of plaque. Okay, a formation of lipid plaque inside the vessel. Okay, so that obstruction can happen. Okay, it is causing obstruction in the vessel. As you can see, this is a normal size of a vessel. When an atherosclerotic plaque is formed, it will obstruct the vessel, causing the lumen narrowing. As you can see, this is a lumen now. Okay, so it is a very common disease. Okay, and you should know the risk factors, which is very important. You should know the risk factors of the atherosclerosis, which are the smoking, hypertension, dyslipidemias, diabetes. These are the modifiable risk factors. You can modify the smoking. You can give the patient drugs to prevent the hypertension. You can give the patient dietary changes and the drugs to prevent the dyslipidemia. Similarly, the diabetes. So these are the modifiable risk factors. The non-modifiable one includes the age, sex, family history. Okay, very important. Okay, and please note that it is a disease of the elastic arteries involving large and the medium size arteries only. Okay, this disease involves only the large and the medium size. Okay, and it causes the buildup of the cholesterol plaque in the tunica intima. Very important, which is the innermost layer of the arteries. Okay, you should always remember the most common location of the atherosclerosis. They will give you the history of a patient with atherosclerosis, and they will ask you what could be the most common location. Okay, or and they can also ask you the sequence. Okay, so like I told you, large and the medium muscular arteries are involved. The largest one is the abdominal aorta. Okay, then comes the coronary artery, then comes the popliteal artery, then the carotid, and then the circle of Willis. Please remember this sequence. It is very important. They will give you a history of atherosclerosis. They will give you one of these options or two of these options, and they can ask you what would be the most common locations. Okay, you will choose the most common one only in this sequence. Abdominal, then the coronary, then the popliteal, then the carotid, and then the circle of Willis. Risk factors we have discussed. The symptoms, because of the obstruction in the blood supply, okay, you're going to have a supply demand mismatch. Remember this term, very important. You're going to have a supply demand mismatch. Okay, and because of the supply demand mismatch, you're going to have a hypoxia, ischemia that causes the pain. Okay, if the supply demand mismatch happen in case of heart, that can lead to the angina. If it had happened in the peripheral tissues, okay, or your limbs, that can lead to the claudication. Okay, but sometimes it could be asymptomatic also. Okay, so the most common symptom is the pain actually because of the supply demand mismatch. Okay, then the progression of the atherosclerotic plaque is very important. Okay, and you should note the fact that the pathologic process for the atherosclerosis, it started in the teen age only. Okay, in the age of 10, the 15s and the 20. Okay, the process of the atherosclerosis is started in the 15 to 20 years of age. Okay, and at that time you will see some lipid plaques inside the arteries. Okay, the earliest lesion, very important, the earliest lesions are the fatty streaks, which are the lipid plaques inside the arteries. Then the progression of these lipid plaques will occur, and that can lead to the atherosclerosis. So whenever you encounter a case or a question where the patient, where the stem mentioned a patient, and in the autopsy, the doctor found some kind of a yellowish deposits in the arteries, and they will ask you what these deposits could be. In the teen patient, they will ask you. So these are the fatty streaks, the earliest lesion of the atherosclerosis. Okay. Then after the fatty streak formation, whenever the first thing for the progression of this atherosclerosis is the damage of the endothelial cells. Very important. They will ask you what could be the earliest thing that happens in the atherosclerosis formation, that is the damage of the endothelial cells. Whenever the damage happens, all these lipids which are in the blood, they will be leak into the endothelial layer. Okay, and when these lipids leak into the endothelium, as you can see, the damage happened, and the lipids will be leaked inside the endothelium. Along with the lipids, the macrophages and the monocytes will also leak inside the endothelium, right? The monocytes will digest the proteins, sorry, these lipids, they will phagocytose these lipids, and they will become the foam cells. Okay, very important. The lymphocytes, which are present in this tissue, they will stimulate the macrophages to activate and to phagocytose these lipids, and further they will become the lipid-laden macrophages. Okay, and this is the earliest lesion, the fatty streak, that you will see in the teenage patients. Okay, now what's going to happen after the foam cell formation and the fatty streak formation? They will release the cytokines. Okay, and they will release the fibroblast growth factors, very important. Oh, sorry, they will release the platelet-derived growth factors, not the fibroblast. They will release the platelet-derived growth factors, which is released from the platelets, and they will stimulate the smooth muscle cells to migrate on the surface of this plaque. As you can see here, the platelet-derived growth factors, as you, if you guys remember from the general pathology section, I have discussed this, that the platelet-derived growth factors, they stimulate the smooth muscle cells to migrate, and by the migration, okay, they can become over the surface of the plaque to form the cap of this plaque. Okay, now these smooth cells, they will release the fibroblast growth factors. Please remember, the fibroblast growth factors, they do not release by the fibroblast, but by the smooth muscles in case of atherosclerosis. Okay, and they will cause the formation of this cap. Very important. They will cause the formation of this cap. Now the thickening of this cap will determine how much the stable your plaque is. Okay, if the cap is very much thickened, that means the plaque is kind of very much stable and it won't cause a thrombosis. But if the cap is thin, okay, then this atherosclerotic plaque can rupture, and when the rupture happens, it can lead to the formation of thrombus. Okay, that can cause the infarction to the tissue, right? So the thickening of the cap is responsible for the stability of the plaque. Very important. Okay, and yeah, that would be all. So if the step one asks you what cells are involved in the atherosclerosis formation, first are the endothelial cells, second are the macrophages, third are the lymphocytes, fourth are the platelets, and five are the smooth muscle cells. No other cell is involved in this process. Only 5 cells are involved. Okay, endothelium, platelets, macrophages, lymphocytes, and the smooth muscle cells. They will cause the everything. Okay. Yeah, that would be all. And whenever you try to stain the atherosclerotic plaque, you will always see an emptied area. Why? Because whenever you try to stain the area, and the washing thing will also happen. Whenever you try to whenever you try to stain a tissue, you will have to wash the tissue after the staining. And after the staining, when you wash the tissue, the cholesterol will be gone by the washing, and that's why you will always have the empty area, that all the plaque you are seeing when this all plaque you are seeing with the lipid laden area, all this lipid laden area, whenever you try to visualize in the H&E stain, it will always seen as an emptied area. Okay, because of the loss of this cholesterol while washing. Very important. Okay, and yeah, that would be everything about it. Then we also need to know the complications. Yeah, after the atherosclerosis formation, there would be an inflammation thing going inside the body. Wherever this plaque form, there will always be a continuous inflammation. Now, because of the inflammation, they will release the cytokines, which will release the metalloproteinases that will destroy this cap. Okay, and the smooth muscles will form this cap. So there would be always a balance between the destruction of the cap and the formation of the cap. And if the inflammation is too much, then the destruction of the cap will happen, and that can lead to the thrombosis. Okay, and because of the inflammation, the tunica media will damage. Okay, this contains the collagen and the elastin. Because of the damage, it can lead to the aneurysms. Okay, it can lead to the ischemia. It can lead to the infarction and the peripheral vascular diseases, thrombus formation. The thrombus can dislodge and can form the embolus. So that's everything about the atherosclerosis. Any doubt on it?
Yeah, I have one question.
Yes.
Like, what's the role of lymphocytes in atherosclerosis?
They will activate the macrophages. Remember, macrophages need to be activated before they can phagocytose anything, before they can kill anything, right?
Yeah. Okay.
So the CD4 cells, they will activate the macrophages to become the foam cells.
Okay. Thank you. Got it.
So please remember the location, very important. Please remember what type of arteries are involved. Please remember the risk factors. Then the symptoms because of the obstruction. You can have the pain, angina, claudication. Remember the pathological process which is involved in the atherosclerosis. First thing would be the endothelial dysfunction. The earliest lesion would be the fatty streak, which is seen in the teenage patients. Then what kind of cells are involved? After the atheroma formation, the stability of atheroma dependent upon the cap. If it is thickened, if it is thin cap, okay, inflammation would be there to destroy the cap. Formation of the cap is by the smooth muscles. Whenever the inflammation wins, the cap will be destructed. That can lead to the formation of thrombus, and the embolus. Infarction can occur. The complication similarly, because of this ongoing inflammation, you can have a damage of the tunica media that can lead to the aneurysm formation. Ischemia because of the plaque formation can happen. Infarction can happen. Thrombus, embolism can happen, right? So the complication, progression, symptom, risk factor, locations. Study them in these headings. You will be able to remember this.
I have a question.
Yeah, please ask.
Where does platelet derived growth factor come from? Does it
From
come
platelets.
from? Okay, but I think somewhere in New World I have studied. I had a question. They asked
Yeah.
about EDGF. So
Yes.
it was from activated macrophages.
Yeah. Actually, not single cell, but multiple cells can secrete them. Major of them are the platelets. If you study the question carefully, that the you will also mention this fact that the platelets will see the name. The platelets derived growth factors. They are derived by the platelets itself, right? And that's the only role of platelets in the atherosclerosis formation. Okay, that's the only role of platelets, to secrete the PDGF, which can activate the these smooth muscle cells. Okay.
Okay.
So majorly it is released by the platelets and minorly also by the activated macrophages. Okay, then comes the aortic aneurysm formation. See here that this atheroma is also responsible for the aneurysms, right? So it is a major cause of the aneurysm formation. Okay, when you say, in what conditions you say that the aneurysm formation is actually occurred? Okay, whenever the dilation is more than 50% above the normal. You have a normal artery, and whenever it is dilated more than 50% of its original size, you will call it a aneurysm. Okay, so it is a pathological dilation of the aorta. Okay, and because of the dilation, what can happen? The nearby structures can be compromised, can be compressed. That can lead to the symptoms. The blood supply to the certain organ could be lost. That can cause the symptoms. Okay, and because of this aneurysm formation, you have a turbulence of the blood flow there, right? And because of the turbulence, you will have this sound. The murmur sound could be there, or there's something like that. Okay, the bruit sound you will see. Okay, the bruits could be heard over that area where the aneurysms are formed. Okay, so these are kind of a signs of the aneurysms. Generally, all the aneurysms are asymptomatic until they rupture, and whenever they rupture, they can cause a very severe pain along with the hemodynamic instability. Okay, whenever the aneurysm rupture, they will cause a very severe pain, and because of the hemorrhage, you will have the hemodynamic instability like the hypotension and the high heart rate, the hemorrhagic shock. Okay, these are generally symptoms of the aneurysm. So let's discuss the two aneurysms. One is the abdominal aorta aneurysm, and second is a thoracic aorta aneurysm. Okay, abdominal aortic aneurysm, it is a most common type. Okay, the risk factors are the atherosclerosis. Remember the most common location of the atherosclerosis?
Aorta.
Exactly, abdominal aorta. And so the most common kind of risk factor for the abdominal aorta aneurysm is the atherosclerosis. Okay, and the histories can include the tobacco smoking. Okay, okay. Then the age is very important. The male is very important. Most commonly it is seen in males than the females. Family history is important. Okay, sometimes the hypertension history is also important, right? But see, the diabetes is not an important cause of the abdominal aorta aneurysm. Very important. Diabetes is not the cause. Please remember this fact. Diabetes can cause the atherosclerosis. Okay, and then atherosclerosis can cause the abdominal aorta. but this diabetes is not a direct cause of the aneurysm. Okay, so if the step one will give you a history of a patient with the abdominal aorta, they will ask you what could be the risk factors for the patient. They will give you the combination of 3 or 4 risk factors in the options, and you have to choose the right option, right? So do not choose a diabetes because it is not a risk factor. Only the smoking, age, and the male, having a male history is very important. Age is very important. Smoking is very important, and atherosclerosis is very important for the abdominal aorta aneurysm. Okay. Now, just give me a second. Yeah. And what we're gonna have? You're gonna have this damage of the tunica media. And see, the tunica media actually contains 2 things. One is the collagen, and second is the elastin. Okay. And whenever you damage your tunica media, okay, what's gonna happen? The elastin would be lost, and if the elastin would be lost, the compliance of the artery will become so much increased, and as a result, the aneurysm formation will occur. Right. Second thing, because of the loss of collagen, okay, the weakening of the walls will happen, and that's why the chances of the aneurysm rupture is very much high. Okay, and please remember, in case of abdominal aorta aneurysm, you're gonna have a transmural inflammation. Okay, you will have the inflammation of the tunica media, you will have the inflammation of the tunica intima, and you will have the inflammation of tunica externa. So a transmural inflammation would be there in case of abdominal aorta aneurysm. Okay, and the cystic medial degeneration will happen in case of thoracic aorta aneurysm. They will ask you the pathologic process, so please remember transmural inflammation in case of abdominal aorta aneurysm. Okay, and the location of the abdominal aorta aneurysm is most commonly infrarenal, distal to the origination of the renal arteries and before the bifurcation of the aorta. Okay, the aorta will be bifurcated in which arteries?
Common iliacs.
Exactly, common iliac arteries. So the location of the aneurysm is below the renal arteries and before the iliac arteries. Okay, very important. Okay, so what symptoms you can get? Because of the aneurysm formation, the nearby structures can be compromised, compressed. That can lead to the flank pain, okay, or any nerve compression from the spine, because as you know that this artery, see in the CT scan, the artery is kind of very much anterior to the vertebra, right? So all the nerves which are coming from here, they can be compromised, and that can lead to the paralysis, right? Most often the symptoms are would not be there. The patient must be most of the time the patient will be asymptomatic. Symptoms will only happen when the aneurysm actually rupture, and whenever the aneurysm rupture, that can lead to the flank pain. Okay, a very severe abdominal pain would be there. Okay, you will get a nerve damage again. You will get a hemodynamic instability. Hypotension would be there. Shock would be there. High heart rate would be there. These are the symptoms. Okay, if you get the anterior rupture, very important, if you get the anterior rupture, then you can have an intraperitoneal bleeding. Okay, and if you have a posterior rupture, then you can have a retroperitoneal bleeding. Okay, because this aorta, it is just behind or just posterior to the peritoneum layer. Okay, so if the anterior rupture occur, it can lead to the intraperitoneal bleeding. If the posterior rupture occur, it can lead to the retroperitoneal bleeding. Okay, and yeah, that would be all about the abdominal aorta aneurysm. Then comes a thoracic aorta aneurysm, which is seen in the thoracic cavity. Okay, it is due to the cystic medial degeneration, which is an age-related phenomena. Okay, you have the degeneration of tunica media, which contains the collagen and the elastin. The damage of the elastin can lead to the formation of aneurysm, and the damage of the collagen can lead to the loss of strength of the artery that can lead to the rupture. Okay, risk factors include the hypertension, bicuspid aortic valve, okay, and the connective tissue disease like Marfan syndrome. In the Marfan syndrome, you're having a very a very high rate of the cystic medial degeneration. You will get this thing in very early age. Okay, and that can lead to aneurysm formation. It can also be associated with the endarteritis. Remember the tertiary syphilis from the microbiology section. I've told you that in case of syphilis, you're going to have the endarteritis. And when the endarteritis affects the vasa vasorum, which which supplies the aorta, blood supply to the aorta, it can lead to the compromised supplying of the aorta. That can lead to the inflammation, and that can lead to the aneurysm formation. right? So these are the causes of the thoracic aneurysm. Remember the cause, cystic medial degeneration. And because of the aneurysm formation, if the aneurysm happens at the aortic root, that can lead to the aortic root dilation, which is a cause of the aortic valve regurgitation. Very important. You will get a murmur, a diastolic murmur would be there in this scenario. Okay, and generally this case is kind of asymptomatic. Symptoms sometimes can happen with a chest pain because of the nearby structure compromisation. Okay, and the symptoms most commonly happen when this aneurysm actually rupture. Okay, and whenever the aneurysm rupture, you will have a very severe chest pain. Along with the chest pain, you will also have the this hemodynamic instability. Okay, sometimes because of the aneurysm formation, you can also have you will also have the compression of the nearby structures like the laryngeal nerve that can lead to the hoarseness. You can have the compression of the esophagus that can lead to the dysphagia. So it would be a patient having a very long history of dysphagia, hoarseness, okay, and a chest pain. And suddenly, when the patient come to your clinic, he is starting having a very severe chest pain and a hypotension and a very this tachycardia. And that's how you know that the patient was having a history of thoracic aneurysm and now he's having a rupture of this aneurysm, right? On the chest x-ray, because you're having a hemorrhage in the chest, you're having a very widened mediastinum. Okay, and because of the hematoma formation, you can also have the tracheal deviation. Very important. A tracheal deviation and the widened mediastinum because of the hemorrhage. Okay, any doubt on this page?
No.
Okay. So remember the location, remember the cause, remember the pathologic process, remember the symptoms. Symptoms always the pain and the hemodynamic instability. Yeah, that's a case of stable versus unstable atherosclerosis. In case of a stable atherosclerosis, you're having a very slow growing plaque. And because the plaque is kind of very slow growing, the collateral blood supply formation can occur. Okay. And when the collateral blood supply formation can occur, even if the artery lumen become very much narrowed, the symptoms of ischemia won't occur. Okay. And this is a case, one of the case when the patient is having a very stable atherosclerosis and the patient is found to be having a stenosis of the artery more than 90%. And even after 90% of stenosis, the patient do not having the patient is not having any kind of symptom of the infarction. So they will ask you what would be the case. It will be the case of stable atherosclerosis. Okay, this must be a slow growing plaque and it must be having a very thick cap. Remember, thick cap is very important. In case of unstable atherosclerosis, they're having a very thin cap. They have a high inflammation, high metalloproteinases activity, and a very high growth. Okay, so the plaque will rupture at a very early stage before the collateral blood supply formation can occur, and that can lead to the myocardial infarction. Okay, but remember I told you your heart will do anything to prevent the infarction condition. Okay, and only after every adaptation is lost, okay, every adaptation is compromised, the heart will get the infarction. So before that, heart will do anything to prevent itself. Okay, that's an important thing. Okay. Then comes a traumatic aortic rupture. Okay, you first need to know the location of the traumatic aortic rupture, which is the ligamentum arteriosum. Remember I told you about that. This part is kind of very immobilized area because of this presence of ligament, and rest of the part is mobile. So whenever you have a high speed accident, in case of any car or a bike, okay, then sudden stop or sudden acceleration, okay, sudden deceleration or sudden acceleration, what's going to happen, this part can rupture because it's a very weak spot, and that can lead to the hemodynamic instability. You will have a hypotension, you will have a shock, you will have a tachycardia, you will have a chest pain, you will have a widened mediastinum, okay, because of this hemorrhage in the chest. Okay, and they will ask you the location, which is a thoracic, which is the aortic isthmus, the location where the ligamentum arteriosum attaches to the aorta. Okay, chest pain would be there, abdominal pain could be there, difficulty breathing would be there, BP decreasing would be there, increase in the pulse would be there, tachycardia would be there, and the widened mediastinum would be there. This is a traumatic aortic rupture. Then comes the aortic dissection. Okay, and it is basically a longitudinal tear of the tunica intima. Okay, so let's see. You have this vessel, aorta. The innermost vessel is a tunica media, the intima. Then come a space, and then come a layer which is a tunica media. This is a tunica media, and after tunica media you have this tunica externa. Okay, so whenever a tear is happen in the tunica, media, whenever tear, intima, whenever tear is happening in this tunica intima, all the blood can be go into the tunica intima. Okay, and the blood is now started running in between the tunica media. Okay, so a longitudinal tearing, and after this tear, a new cavity is formed which is filled with the blood completely. A kind of hematoma structure is formed because of the tearing. Okay, because of a high speed pressure, high pressure of the blood that can that can be passing through the tunica media. This can lead to the aortic dissection. Okay, and the single most important risk factor for the aortic dissection is the hypertension. Very important. The single most important risk factor for the aortic dissection is the hypertension. Okay. Other risk factors include the bicuspid aortic valve, the inherited diseases like the Marfan syndrome or the Ehlers-Danlos syndrome. Okay. How does it gonna present you? It will present you with a tearing chest pain. Very important. It will be very tearing chest pain. Okay. And because of this tearing, okay, you're gonna have a formation of new cavity. Okay. And as a result, the real lumen of the artery, as you can see this thing. This is the formation of a false lumen after the tearing, and this is the true lumen. Initially, the size of the arteries is this much, but as you can see, the lumen of the arteries is very much narrowed, and as a result, the blood supply to the organs will also be decreased. Okay, the blood supply to the hands will be decreased. That can be causing the claudication. Okay, and the blood supply to other organs like the heart, like the lungs, like the kidneys, they will be decreased. That will be causing the symptoms. Okay, and because the blood supply to the heart is lost, hand is lost, what gonna have? You will have a unequal BP in the arms. Okay, very important. You're gonna have the unequal BP in the arms because of the compromisation of the blood supply to the one of the hand. Okay, one of the arm. So very important, unequal BP in the arm, and it is more than 20, I think. Whenever you have a BP change, okay, more than 10 or 20, you can say that it must be a case of aortic dissection. It could be a case of aortic dissection. Okay. But if you have a BP difference less than 10, it could be a normal scenario. Okay, very important. You will have a chest pain which is radiating to the back. Very important. A tearing chest pain which is radiating to the back. Okay, unequal BP in the arm. When you do the chest X-ray, you will see the chest X-ray widening, the mediastinal widening. Okay. On the CT scan, you can see the false lumen formation, this whitish part, and this is a part where tearing occur. Okay, there is a septa formation between the two areas. Okay, and the CT will determine, and see these are two type of aortic dissection can occur. One is a Stanford A and one is a Stanford B. In case of the Stanford A, the ascending aorta is ruptured. Okay, the dissection will occur in the ascending aorta, and as a result, if the ascending aorta is ruptured, if it is become dissected, then both the ascending as well as the descending aorta could be involved, and even this blood could go back into the heart. Okay, and it can lead to the cardiac tamponade. Very important, it can lead to the cardiac tamponade. It can lead to the aortic regurgitation. Okay, it can involve a descending aorta. So the dissection will be seen both in the ascending as well as the descending aorta. As you can see in this CT scan, you have the false lumen forming both in the ascending as well as in the descending aorta. As you can see, septum is present in both the ascending as well as in the descending aorta. That means it is a Stanford A type. Okay, and the treatment would be the surgery only. In case of Stanford B type, it will involve only the descending aorta, not the ascending one. And as a result, false lumen will be seen only in the descending aorta, not in the ascending aorta in the CT scan. So they will give you a CT scan and they will ask you what kind of dissection is it, Stanford A or Stanford B. So you need to look for both of these arteries, like ascending and the descending one. If both are involved, then Stanford A. If only one is involved, which is the descending one, then the Stanford B. And the treatment will be first the beta blockers, then the vasodilators. Very important. First, you will give the beta blockers, then only you can give the patient vasodilators. By giving the beta blockers, you're actually reducing the heart rate. Okay, so you're reducing the change in the blood pressure, first thing, and the frequency of change in the blood pressure. Okay, by decreasing the contractility, you're decreasing the blood pressure. Okay, so decreasing the change in the blood pressure, and by decreasing the heart rate, you are decreasing the frequency of change in the BP. Okay, and only after the beta blockers are given, you will give the patient vasodilators. If you give the vasodilator first, then the blood supply to that area would be very much increased, and as a result, it will cause the worsening of the symptoms. Okay, it will cause a worsening of the tear if you give the patient vasodilators first. So only after beta blockers you will give the patient vasodilators. Okay, and all the symptoms of the aortic dissection is because of the organ ischemia. Stefan will ask you, because of the organ ischemia, you will get the symptoms. Okay. Yeah, that would be all about the aortic dissection. Any doubt?
Yeah, could you please explain me the reason why vasodilators are not given before beta?
See, if you give the patient vasodilators, what's gonna happen to my heart rate?
It will increase as a reflex.
And what's gonna happen to my cardiac output?
It will increase.
And what I told you already, in case of a dissection, the single most important factor is hypertension. Because of this high BP, because of this high flowing BP, you're having a tear in the intima, right? And if the BP is further increased, if the blood flow to that particular area is further increased, what's going to happen? The tear will increase, right?
Yeah. Okay.
So that's why you cannot give the these vasodilators first. You need to give the beta blocker so that the BP could be decreased. Okay, by decreasing the cardiac output, and the heart rate could be decreased. Okay, that's all.
Okay. And one more question, is the reason for aortic dissection in Marfan syndrome the same as for aortic dissection, that is cystic medial degeneration?
Yes, exactly. See, if you go back and I think they didn't mention it, but one of the complication of this thoracic aorta aneurysm is the rupture, and the second complication is the dissection. Okay, so after the formation of this aneurysm, you can have the dissection also, and this is because of the cystic medial necrosis. They didn't mention it here, but they've mentioned the biochemistry section. Okay.
Okay. Yeah.
So yeah, you can correlate it from there. Okay, any more doubt?
Yeah, I have one more doubt.
Yes.
It's from the vasculitis section. I want to correlate with the unequal BP in the arms over here.
You will see. Yeah, you will see that
Takayasu.
artery. Yeah, exactly. You will see that in there also. But see, in case of Takayasu, you can have an unequal BP in the arms and as well as the limbs. In the lower limbs also, right? So yeah.
Okay.
These conditions can occur. Don't worry. We will discuss that later again. You will have an unequal BP in case of aortic dissection also, and as well as
okay.
in the vasculitis also. So yeah, we will discuss that later again. Don't worry about that.
Okay.
But yeah, if you're having this chest pain and if you're having this widened CXR, then you can just go for dissection, not for the vasculitis. Okay, so different symptoms, different history would be there.
Okay.
Okay, then comes the ischemic heart diseases. And remember, ischemia is a complication of the atherosclerosis, one of the complications, right? I'm sorry, I just lost my connection. I will repeat it again. Remember, all these ischemic conditions can only happen whenever you have a supply-demand mismatch. Whenever the supply is less or whenever the demand is more, okay, and a mismatch between these two things occur, it can lead to the ischemia, right? So first is the angina, okay, and in angina there won't be any necrosis. There just the ischemia of the area will happen. Okay, it is happened due to the secondary to the coronary artery narrowing, okay, which could be happened by the spasms, or it could be happened by the atherosclerosis formation, like we have discussed previously, right? So three types of anginas are there. One is the stable angina, second is the vasospastic angina, third are the unstable angina. The stable angina generally occur by the most commonly occur because of the secondary to the atherosclerosis. Okay, and the symptoms of the angina very important.
the symptoms of the angina will only occur when the stenosis is more than 70%. Step 1 will ask you this, please remember. Only when the stenosis is more than 70%, the symptoms of the angina can occur. And the symptoms only occur whenever the supply-demand mismatch will happen, which is during the exertional activities. Whenever you do the exercise, you're actually increasing the demand of the heart. But the blood supply cannot be increased because of that, because of this occlusion, and as a result, the patient will get the chest pain. Okay. In the normal circumstances, when the patient is not exercising, it won't cause any symptoms. Okay. So on the ECG of the patient, you will get the ST segment depression, and you will get a subendocardial ischemia. Very important. They will ask you the location. In case of angina, it would be the subendocardial ischemia, because this is the watershed region in the heart, right? How you can treat the condition? By giving the patient nitroglycerin. Okay, very important. NTG, which will release a nitric oxide that can cause some vasodilation. Okay. Then comes the vasospastic type angina. In this case, you're having the vasospasms. Okay, and it could be seen in the younger patient. See, the angina case, which is because of the atherosclerosis, and you guys know that age is a very most important thing for the atherosclerosis. So you will see the stable angina only in the old age patients. But a vasospastic angina could be seen in patient having, with the age of like 25 or 30s only. Okay, so whenever you encounter a patient who is very young, 20s or 30s, and he's having the angina symptoms, it must be the vasospastic type. Okay. It is happened because of the coronary vasospasms. What's going to happen actually? You're having the dysfunction of the tunica intima and the receptors on the endothelium for the acetylcholine. Okay, remember the muscarinic receptors in the endothelium, they will release the nitric oxide and they can cause the vasodilation, right? But the receptors in the tunica media inside the muscles, inside the smooth muscles, they are the muscarinic types and they can cause a vasoconstriction. Remember?
Yeah.
Just give me a second. So guys, remember?
Yes.
I think I'm keep on losing my connection. Please hold on for a second, guys. Let me just reconnect again. Sorry about that. Okay, so guys, remember? I couldn't hear anyone.
Could you please repeat the receptor thing?
See, you have the muscarinic receptors both in the myocardium, both in the smooth muscles of the arteries, as well as in the endothelium. Okay. In the endothelium, if the muscarinic receptors are stimulated, they will release the nitric oxide that can cause a vasodilation, right? But if the muscarinic receptors inside the inside this smooth muscles are stimulated, okay, then they will cause a vasoconstriction. Okay, remember from the chapter,
Yeah.
the pharmacology, right?
Yes.
So in this vasospastic angina, you're actually going to have an endothelial dysfunction, and because of this endothelial dysfunction, the muscarinic receptors in the endothelium can never be stimulated, and as a result, the receptors in the smooth muscles, they will be stimulated and they will cause the vasospasm. So whenever you have a high vagal tone which releases the acetylcholine, they can cause the vasospasms, which generally occur in the night time. Most commonly, the symptoms will occur in the night time. Okay, when the patient is very quietly sleeping and the parasympathetic tone is very much high. Because of this high parasympathetic tone, the vasospasm will occur and the patient will get the symptoms of angina. Okay, smoking is a risk factor again. Okay, hypertension, hypercholesterolemia, they are not the risk factors. They are the risk factors for the stable angina. Triggers can include the cocaine. Remember, the cocaine can cause the vasospasms by the alpha-1 stimulation. Alcohol can cause it. The triptans, which releases serotonin, and serotonin is a vasoactive agent. They can cause the vasospasms, right? You will treat them with the vasodilatory agents like the calcium channel blockers, nitrates, and the smoking cessation if applicable. Okay, very important. And So you will have a ST segment elevation in that, not the ST segment depression, but the ST segment elevation. Because of a complete vasospasm, you will have a transmural ischemia. That's why the this ST segment elevation, very important. Okay, and any drug which can increase the vagal tone, like the acetylcholine, like the ergotamine, they can cause the vasospastic angina. Very important. If you give the acetylcholine to a stable angina patient, it will cause a vasodilation. It will cause a resolution of symptoms. But if you give the patient acetylcholine to a vasospastic angina patient, it will cause a vasospasms instead. A very important differentiation factor, a very important test. Okay, you will give the patient a vasodilator agent. Okay, a parasympathetic mimetic agent like a pilocarpine or any other drug which will release the acetylcholine, and they will cause a spasm. That is a test for it. Okay, right. Then comes the unstable angina, in which the thrombosis of this stable plaque is happened. Okay, the thrombosis of stable plaque is happened, and as a result, about 90% of the artery is being occluded. Okay, incomplete occlusion occur. Okay, blood supply is still there, so you will get the subendocardial ischemia only. You will get the ST segment depression. See, no necrosis is going to happen because this is a characteristic feature of the angina. No necrosis will happen in case of a angina, right? So you won't get any elevation of the cardiac biomarkers. And that is the important differentiation factor between the non-ST segment elevated myocardial infarction and the unstable angina, right? You won't get any elevation of the cardiac biomarkers, but you will get the ST segment depression and you will get the chest pain. That's all about the angina. Any doubt?
No. Thank you.
Then comes the coronary steal phenomena. See, whenever the angina occurs, whenever the whenever the atherosclerosis formation occurs, okay, you will have the narrowing of the artery lumen, and like I told you, your heart will have a mechanism to increase the blood flow. Remember the autoregulation, it will release the adenosine, it will release the CO2, it will release the nitric oxide to cause the vasodilation, right?
Yeah.
So as as this atherosclerotic plaque is progressing and the occlusion is increasing, the lumen is getting keep on narrowing. Okay, what's gonna happen? These the adenosine, the CO2, and this nitric oxide, they will keep on releasing from the cells, right? And as a result, the vasodilation will be happening. So this thing will maintain the blood flow to the heart. Okay, only after the 70% occlusion occur. Okay, all of the adenosine is used, all of the CO2 is used, all of this nitric oxide is used. Okay, and now no further dilation of that segment of the artery can happen. Okay, so that's why only after 70% occlusion you will get the angina symptoms, because furthermore your heart cannot dilate the arteries. Okay, so now let us suppose this is the one coronary artery and it's give off two branches. Okay, like that. If occlusion happened to this artery and this artery is maximally dilated, okay, and I give patient further more vasodilators, okay, to dilate the segments, I'm giving the patient a vasodilator drug, okay, and many the arteriolodilators, okay, what's gonna happen? They will dilate that segment of the heart which is not dilated, which is non-atherosclerotic. So this part which is normal, it would be dilated, okay, and as a result, all the blood which was going to that area and that area, okay, it will be diverted to this area only, because this area is no further dilated, right? It is maximally dilated already. So even if you give the patient vasodilators, they will only dilate that segment of the heart which is normal, not this disease segment. And as a result, the shifting of the blood will occur to this dilated part. And as a result, what you will get a further ischemia of the heart. Okay, this is the coronary steal syndrome. You understood it?
Yes.
Yes,
Okay.
yes.
Very important. So whenever you give the patient vasodilators like a diparacetamol, okay, or any other like hydralazine or any other arteriodilators like the calcium channel blockers, even what's going to happen? They will just dilate that area which was absolutely normal, and as a result, the ischemia of the myocardium will be occurred further by the stenotic vessels. Okay, and this is the thing which you uses for the pharmacological stress test. You will give the patient any other any drug which increase the demand, the metabolic demand of the heart. But you know that the supply cannot be further increased, and as a result, the patient will get the ischemia. Okay, you will check them for the, you will run some test and you can diagnose which part is is having the ischemia, and you can diagnose the condition. This is the pharmacological stress test. Very important.
I have a question.
Let's ask.
What's the difference between the coronary steal syndrome and the subclavian steal syndrome?
In case of subclavian, it is happening in subclavian vessels. In case of coronary syndrome, it is happening in these coronary vessels.
Okay, but the cause is the same, like it could be applied.
Exactly. Cause is same because of the atherosclerosis. Yeah, because of the atherosclerosis, there will be stenosis in the subclavian vessels, and as a result, all the vertebral vessels which are supplying your brain, okay, they, instead of supplying to the brain, they will supply the, you have, if you remember the anatomy, this is your arch of the aorta. Okay, it gives up. This is the, it gives up three branches. One of them is the left subclavian artery. Let us suppose the stenosis of this left subclavian artery occur. Okay, and you also have these vertebral vessels. Okay, which are originating from the subclavian arteries. Remember?
Yes.
These are the vertebral vessels which are originating from the subclavian arteries. If the stenosis happens in this place, then at certain point in the brain, they will be joined in each other, right? And they will supply the brain further, right? When the stenosis happens in that area, the blood supply to this part is lost. And as a result, all of the blood which was going to the brain, instead of going to the brain, it will be go to the, in this direction, supplying to the subclavian part. We studied it in neurology section. I think 2021 edition mentioned it in the CBS part. Okay, but I mentioned that in the neurology section, so you have to wait for that part. Okay, we will come to that. But both are same things. In both our syndromes, you will having a stenosis of the vessels.
Okay.
Then comes a sudden cardiac death, and like I told you, the most common cause is the ventricular fibrillation. Nothing to tell anymore. The QT prolongation, the Buccara syndrome, the myocardial infarction. In every cases, you will get the ventricular fibrillation, and that can lead to a sudden cardiac death. Then comes the chronic ischemic heart disease, okay, which causes a progressive onset of the heart failure over the many years due to the chronic ischemia. Because of the chronic ischemia, you're having a dysfunction of the myocardium, and that can lead to the heart failure. Okay. One of the important thing which is associated with the angina is the myocardial hibernation. Very important, the myocardial hibernation. Like I told you, your heart will do anything to prevent the infarction in it, right? First thing we have studied that it will form the collateral vessels in case of a stable angina, okay, to prevent the loss of blood supply. Second thing it will do is the myocardial hibernation, and just like a normal hibernation, the myocardium will decrease their metabolic demands. Okay, they will decrease the contractility, they will decrease the heart rate, they will decrease the cardiac output. Okay, and ultimately they will meet the metabolic demands same as the blood supply, so that the supply demand mismatch can never happen. And this is known as the myocardial hibernation. And as soon as you resolve the angina, okay, you will do the percutaneous coronary intervention. Whenever you do that, you will increase the blood supply. And suddenly after increasing the blood supply, you will see the increase in the demand of the heart. You will see the increase in heart rate. You will see the increase in contractility. You will see the increase in cardiac output. So a classical question could be a patient who is having a bradycardia and this and a loss of cardiac output and a low BP. Okay, and as soon as the patient is went out of the surgery after the PCI, okay, the patient is having an increased heart rate, the patient is having an increased cardiac output. So they will ask you why the patient was having the bradycardia before and not now. And it is because of the myocardial hibernation, a very important phenomenon. Okay. Yeah, that's the myocardial hibernation. In a state of a chronic myocardial ischemia, the blood supply to the organ is lost. Okay, and as a result, the myocardial function as well as the metabolism will be decreased. Okay, so that it can match the blood supply level, right, in order to prevent the myocardial necrosis. Okay, and this could reduce the contractility of the heart rate of the patient. Okay, and whenever you do the revascularization, okay, after subsequent with the subsequent restoration of the blood, okay, the hibernation will be over and the patient will get an increase in the contractility and increase in the left ventricular function. This is known as the myocardial hibernation. It is only seen in cases with the chronic with decrease in the blood supply. Okay, only seen in the cases with the chronic decrease in the blood supply, not with the infarction. Okay, with the infarction you will get a myocardial stunning, if you remember, right, which is a loss of myocardial function because of loss of blood supply. So in case of infarction, you will get a myocardial stunning. In case of angina, you will get the myocardial hibernation. So please note the difference between the two. Okay, then comes the myocardial infarction. Okay, and for the myocardial infarction, we will read this in a theme. Okay, we will organize this in a theme. First of all, we will study the cause of the MI. Okay, then we will study the clinical presentation of the myocardial infarction. Then we will see when the patient come in the department, what diagnostic test you must run. Okay, then after tests are run, okay, what gonna happen to the patient? What are the pathological changes will happen in the disease? Okay, then after the MI episode is over, what complications can happen? Okay, and then finally we will study what are the treatment of the myocardial infarction. So you can note that down. Please try to study this in this thing. Okay, first of all, the cause, then the presentation of the disease, then the tests, then the pathological changes, the complications, and then finally the treatment. If you organize the theme, then you will be able to remember every symptom and every process of the disease very easy. Okay. Yeah.
I had a question. The myocardial hibernation.
Yes.
The take-home message for that is basically you could reverse the systolic dysfunction that's happening in the left ventricle.
Yes.
That's like the big picture here. Like I'm not understanding like what's exactly happening.
See,
in that.
When the angina, when the atherosclerosis happens, and 70% of the lumen is lost. Okay, the blood supply to the heart is lost. Okay.
Mm-hmm.
And in order to match that blood supply, okay, to prevent the supply demand mismatch, okay, the demand of the heart is decreased. The heart will reduce its demands. Okay, it will reduce the heart rate, it will reduce the contractility, everything, so that it can match to the level of blood supply, right, to prevent the necrosis.
Okay.
And as soon as you restore the blood supply, the demand will further increase. So you will get the high heart rate, you will get the high contractility, you will get the high cardiac output.
How would you compare that with myocardial stunning? Like,
see,
how would you...
only in the chronic cases you can have the hibernation. In case of infarction, which is an acute thing, infarction is not a chronic thing, right?
Yeah. Okay.
Only in case of acute scenarios, you will have the stunning. Stunning is kind of a loss of functions. It is not what myocardium is doing for itself. It is happening to it. And the hibernation is a thing which is myocardium doing to itself to prevent the infarction.
Okay, I understand that. So one's more for the acute and one's for the chronic.
Okay, now comes the myocardial infarction. First of all, you have to study what is the cause of the myocardial infarction. This is the previous atherosclerosis. Whenever a patient is having atherosclerosis in any of the coronary vessel, okay, and this atherosclerotic part, this plaque for the ruptures, it will lead to the thrombosis. Okay, and when the acute thrombosis happen, it will lead to the necrosis of the tissue. Very important. Like I told you, in case of angina, no necrosis happened, but in case of this myocardial infarction, you will have the necrosis. Okay, and because of the necrosis, you're having an irreversible cell damage, right? You will have the loss of enzymes from the cell, and that's why you will have the rise of the biomarkers like the CKMB and the troponin. Okay, so the cause is the thrombosis of the atherosclerotic plaque. Now, two types of myocardial infarctions can be there. One is the non-ST segment elevation, and second is the ST segment elevation. In case of a non-ST segment elevation, you are having a subendocardial infarction only. Okay, but in case of a ST segment elevation, you are having a transmural, which is a full thickness infarction. Okay. And like I told you, subendocardium is the region which is a watershed area. That's why the infarction first occur in this area only. Okay. In case of non-ST segment elevation myocardial infarction, you will get the ST segment depression, which is shifting of the J point below the normal value. In case of ST segment elevation, you will get the shifting upward of the J point from the normal value. Okay. So this is the thing for the myocardial infarction. Now, what are the risk factors for the myocardial infarction? Okay, again, just like the atherosclerosis, all of the risk factors which are for the atherosclerosis are applicable for the myocardial infarction. The hypertension, the diabetes, the smoking, the age, the family history. Okay, sometimes you can even get an early myocardial infarction, early age myocardial infarction in the teenage patients or in the infants. If anyone remember the diseases.
Homocystinuria.
Okay, one disease and other one.
Kawasaki disease.
Okay. You can consider this.
Familial hypercholesterolemia.
Exactly, familial hypercholesterolemia. You can also have a very early age of myocardial infarction. Okay, very important to note that. So all the risk factors for the atherosclerosis are the risk factors for the myocardial infarction. Okay. Now we have studied the cause completely. Okay, now what is the clinical picture of the patient when they come to the emergency department? First thing, they will having a chest pain. Okay, and this chest pain is generally a retrosternal chest pain, very important. The patient will complain of a burning chest pain. Sometimes they tell you of a chest heaviness. Sometimes they tell you that it is a squeezing type of chest pain. So burning pain, heaviness, or a squeezing type of retrosternal chest pain would be for the myocardial infarction. Along with the chest pain, the patient can also have a diphoriasis because of the activation of the sympathetic nervous system. They can have a nausea, they can have a vomiting, they will have a high enzyme levels, like lactic acidosis the patient must be having. Okay. And because the pericardium is involved because of pericarditis, the patient will also have a pain in the shoulder, left shoulder, as well as the left arm and the left jaw. Okay. These are the symptoms for the myocardial infarction. Okay. And please remember the most common artery which are occluded. These are the left anterior descending artery, then comes the right circumflex, and finally the circumflex artery. Sorry, the right coronary artery, and finally the left circumflex artery. Okay. We have studied the cause. We have studied the clinical pictures. Now, what are the diagnostic tests that you will run for the MI? The first one is the ECG, and second one is the biomarkers. Okay. For the biomarkers, you will use a cardiac troponin, and second biomarker is the CKMB. For the troponin, it will be raised after the 4 hours. And why it is rising? Because of the cell membrane rupture. Okay, because of the cell membrane rupture, because of the irreversible cell injury, all the enzymes will be leaked out of the cell, right? So the cardiac troponin will rise. It will rise after 4 days, and it will be subside after the 7 to 10 days only. So if a new infarction occur in between the 7 to 10 days, you cannot diagnose it with the cardiac troponin. Okay, then comes the CKMP levels, which rise after 6 to 12 hours. Okay, and they will return normal to the 48 hours. After 48 hours, they will return to normal. And that's why if a new infarction occur, you can diagnose it with the help of CKMP only, not with the cardiac troponin, right? Then you can also have a lactic acidosis. A high anion gap metabolic acidosis could be there because of loss of oxygen to the supply of the tissue. You will get a lactic acidosis. For the ECG segment changes, first thing is the T waves. The first change would be the T wave change. You will get a T wave inversion. Okay. Second change would be the ST segment elevation or depression, respectively. If you get if you get a ST segment elevation or a depression myocardial infarction. And the last change would be the pathological Q waves. Okay, very important, which are the very deep Q waves or the QRS complex. Okay, and they generally represent a chronic, or a previous case of the myocardial infarction. It represents a previous case of the myocardial infarction. Okay, and how would you localize a myocardial infarction to a certain patient? You have some chest leads. Okay, the chest lead B1, B2, B3, B4, B5, and B6. Okay, and the chest leads AVL, AVR, 1, 2, 3, and the AVF. Now, what part of the heart, okay, these chest leads are representing? See, for the area of the blood which is supplied by the lateral circumflex artery or the lateral wall of the heart, okay, it is represented by the chest lead B5, B6, AVL, and 1. Okay, the interventricular septum area or the anterior wall of the heart, okay, it is represented by the B3, B4, okay, and B1, B2. B1, B2, B3, B4, they represent the anterior wall of the heart, okay. The lead second, third, and the AVF, they represent the base of the heart, okay, which is supplied by the right coronary artery, okay. So whenever you have a ST segment changes in the V5, V6, AVL or 1, you can easily say that it is a lateral wall myocardial infarction, which is for the lateral circumflex artery occlusion. If you have a ST segment elevation in the V3, V4, okay, which is the anterior apical area, okay, or the septal leads, which are V1 and V2, if you have a ST segment elevation in these leads, that means it is an anterior wall myocardial infarction, and which is by the left anterior descending artery occlusion. If you got occlusion in the right coronary artery, it can lead to the inferior wall myocardial infarction, right? And you will have a ST segment elevation in the chest lead 2, 3, and the AV foot. And because the right coronary artery also supplies the SA node in the in the inferior wall myocardial infarction, you can also have the bradycardia. Okay, that's about the localization. So as you can see, the leads B6, B5, okay, B3, B4, B2, and B1. The lead B6, B5, AVL, and AV, and this first lead, they're representing the lateral wall myocardial infarction. Okay, B3, B4, B5, B6, they represent the anterior wall myocardial infarction. This is the anterior wall of the heart. So these are the anterior wall. Okay, see this as a horizontal, and this is a vertical diagram. This is the horizontal diagram of the heart, and this is the vertical diagram. Okay, so these B3, B4, and B1, B2, they're coming out of the page. Okay, and that's why the anterior wall they're representing. And this diagram is it's a vertical diagram. So all these lead to AV foot and the third wave. Okay, they're representing the inferior walls. Okay, they're representing the inferior walls. So you can easily correlate it to there. Okay, understood it this much?
Yes.
Okay, so whenever you get a LAD occlusion, you can have a B1, B2 lead ST segment elevation, which is for the anterior septum, like we have discussed. For the septum, it is B1, B2. For the anterior apical, which is this part, the apex of the heart, which is for the B3, B4. The anterior lateral, which is supplied by the left circumflex artery, okay, and the left anterior descending artery, some part, B5, B6 is involved. Okay, if LCX is damaged, you can have a B6, B5, B6 first and the AVL ST segment elevation. Okay, for the inferior wall myocardial infarction supplied by the right coronary artery, you will have the third, fourth, and the AV foot ST segment elevation. For the posterior descending artery, you will have the elevation in the lead V7, V6, which are kind of posterior, not shown here. Okay, and you generally don't represent it on the diagram also on the ECG part, so you can just forget it. Okay, but in case of a PDA, it's applied again the the posterior part of the interventricular septum. You can just remember it. Okay, and yeah, that would be all. So that's how you can diagnose the myocardial infarction. Okay, and in case if you are having a occlusion of the right coronary artery, you can either have a damage to the left ventricle, or you can have a damage to the right ventricle also. Because it supplies some part of the left ventricle and some part of the right ventricle, right? So how you can differentiate between the left ventricle infarction and the right ventricle infarction? It is
Left,
by
left ventricle infarction will probably be having dyspnea and short and low BP.
Okay, all right.
For the right, you will have pedal edema, and
Exactly.
chest will be clear on auscultation.
Exactly. See,
On
in
the
case
right,
of
you have
yeah,
low heart rate because you got the SA no and AB no.
no, see, low heart
And
rate would be
brain
there in
wave.
both of the scenarios because the RCA is kind of blocked, right? So low heart rate
Okay.
would be there in both. Yes. Someone was saying something too. No. Okay. See, in case of a left ventricular infarction, the left side of the heart is gone, and as a result, all of the blood will be start pulling back into the lungs, right? The pressure will be going back into the lungs. So you will have the lung involvement in case of the left wall myocardial infarction, right? But in case of a right-sided infarction, because only the right side of the heart is gone, the lungs won't be involved. Okay, and the backflow of the blood will be in the venous circulation. So we'll get the edema. Okay, you will get a pulmonary. You will get the hepatic congestion. You will get the splenic congestion. Okay, but no lung symptoms. When the lung symptoms are there, this must be a case of your left-sided infarction, not the right-sided infarction. Okay, the loss of cardiac output will be there in both the cases, because if the right heart do not pump the blood, it won't be get into the left heart, and so again the left heart won't be able to pump the blood. So loss of BP will be there in both, loss of cardiac output will be there in both, but only the lung symptoms will be there in the left side infarction. Okay, not in the right side. Are we good, everyone?
Yes, good.
Okay, then
Yes.
okay, so we have discussed the cause, we have discussed the risk factors, we have discussed the clinical pictures, we have discussed the diagnostic tests, and now we will discuss what are the pathological changes happen, or the microscopic changes, I must say. The microscopic changes and the gross changes in the hearts that will occur. So, for the first 4 hours, you won't see any change in the heart, not in the gross, not in the microscopic, no change. Okay, only after 4 hours you will be able to see any change. Okay, and because the infarction is occurred, okay, so you will get the early coagulating necrosis, very important. And for the coagulating necrosis, you can easily see the boundary of the cell, but inside it, everything is lost. Everything is diffusely pink. Okay, you will see the edema, you will see the wavy fibers sometimes. Okay, if the reperfusion occur at that time, if you do the reperfusion, if you do the PCI, okay, then the reperfusion can occur, and that can lead to the reperfusion injury. Okay, you will have the further increase in the cardiac biomarkers, and we have discussed it already because of the reactive oxygen speech generation. Okay, you will have the, and because of the calcium influx, you will have the hypercontraction of the myofibrils. Very important. So if you do the microscopy, you will see the eosinophilia and the cell boundaries. And for the first 4 hours, you will see nothing. Then within 1 to 3 days, because a necrosis has happened, the neutrophils should be arrived there because of the inflammation, like we have discussed. Whenever the necrosis is there, it will always be followed by the neutrophils, and neutrophils will remain in the tissue, in the necrosis tissue, for 3 days. It is a general rule. Okay, minimum for the 3 days, neutrophils will be there. So if you do the biopsy of the patient, you will see the neutrophils or the neutrophilia in that area for the 3 days. Okay, you will see the inflammatory cells there. And in on the gross examination of the heart, you will see the pallor of the tissue. Remember, whenever you have a infarction in any area of the body, you will have two type of infarcts, like the red infarct or the pale infarct. In case of lungs, in case of liver, in case of intestine, in case of testes, you can have a red infarct. While in other areas which are supplied only by one blood vessel, there will be the pale infarction. So you will see the pale infarction in the first to 3 days. Okay. So necrosis and the neutrophils would be there, and the acute inflammation could be there. Okay. Then after the 3 days up to the 7 days, macrophages will reach there. They will decide whether the inflammation must be continued or the resolution of symptoms will be occurring. So for the first 7 days, after 3 days, 3 to 7 days, you will see the macrophages in the tissue. Okay. And once the macrophages reach there after the 3 days, you can see only after 7 days you will have the macrophages. Only after the 7 days you will started having the granulation tissue formation. The healing process is now started. Okay, you will have the granulation tissue formation in that area. Okay, so if you do the biopsy in first 7 days, you will see just the macrophages, okay, which were phagocytosing the dead cells, and the neutrophils. After 7 days, the granulation tissue will be seen. You will see the type 3 collagen. If you guys remember from the biochemistry lectures, we have discussed that the earliest collagen in the wound healing was the collagen type 3. Okay, very important. And so you will see the red granulation tissue in the cross examination of the heart. It would be a pale infarct which is surrounded by the red granulation tissue. This is seen in the 3 to 14 days. Okay, and most of the complications, most of the complications of the myocardial infarction after the infarction is over would be seen in this time only, when the macrophages were there, phagocytosing in the that tissue. Most of the complications seen in the 3 to 14 days. Okay, then after the 14 days, further, the remodeling phase will be started. Okay, and in the remodeling phase, you will see the type 1 collagen. Okay, you will see the scar formation, and when you see the gross examination of the heart, you will see the gray-white scar. Okay, and when you do the biopsy, everywhere you see is the collagen only. Okay, the collagen and the white scar would be seen in the after 2 weeks. So a general rule, and not just the heart, this thing will always seen in any tissue whenever it undergo any kind of infarction. This thing will see in any kind of tissue. Okay, within first 3 days you will see the neutrophils. From 3 to 7 days you will see the macrophages. After 7 days up to the 14 days you will see the the wound healing phase, the proliferation phase of the wound healing. After 2 weeks you will see the remodeling phase, which is a scar formation. In every tissue you will see this. Okay, so if the step 1 will ask you and that you have done a biopsy in a patient on the 14th day of the of this MI, and they will ask you that this tissue could be seen in which of the following organs also. So they were referring to the collagen type 3. So in what other areas you will see the collagen type 3?
Reticular areas, blood vessels.
Yes, uterus, every tissue which can be stretched, skin, and and all these tissues, you will see the collagen type 3. So they will ask you. And if they ask you that you have done a biopsy after 2-3 weeks, and and you have seen some kind of a tissue in that heart, and they will ask you what other locations this tissue will be present. Not a tissue, but this fibers or this protein would be present. So they were referring to the collagen type 1. It would be in the bone, right? It would be in the skin. It would be in the in the tendons, right? So very important to know the collagen 1 and the collagen 3. Okay, any doubt on the progression of the MI?
No, thank you.
No.
Okay, so we have discussed the cause, we have discussed the clinical picture, we have discussed the diagnostic tests, we have discussed what you will see on the autopsy or on the histology. Now we are going to discuss what you would see in the complications. Okay, as soon as you have the MI attack, in the acute MI attack, the most common complication which can lead to the death is the cardiac arrhythmia. Okay, soon after the patient is having an attack, during the attack, that patient can have the ventricular tachycardia, and that can lead to the sudden cardiac death. So if the step 1 asks you the most common cause of death within the first 24 hours, it would be the ventricular tachyarrhythmia, so it can lead to the cardiac arrhythmia and death of the patient. After the infarction phase is over, if the when the patient is admitted inside the hospital now, all of these things can happen. The first one is the post-infarctious venous pericarditis. Like I told you, for the first 3 days, the neutrophils would be there and the acute inflammation would be there. Okay, and this acute inflammation can involve your pericardium, and that can lead to the pericarditis. So you were having the chest pain, shoulder pain, pain in the arms, pain in the jaw. Okay, and a friction rub. Whenever you use the stethoscope, you can see the friction rub. Okay, abdominal chest pain would be there. Very important. Okay, very important. This the friction rub.
Yeah, I am just entered now.
And when you do
can
the
take the medicine and take today and go tomorrow. Okay.
And when you do the biopsy of the patient, when you do the ECG of the patient, you can see the widespread ST segment elevation in the post-infarctious venous pericarditis. Very important. Okay. Then, like I told you, most of the complication will occur in the 3 to 14 days when the macrophages were there for the phagocytation. Okay, so every complication is due to the phagocytosis and due to the rupture. Okay, the first one is the papillary muscle rupture. Remember, what is the most common muscle rupture? The papillary muscles.
Posterior, inferior.
Posterior medial. Yes, okay, because they
Sorry,
have a single
posterior
supply.
medial.
Because they have the single supply. And what nerve? What artery supplies this muscle?
Circumflex.
Not circumflex. No.
Posterior descending.
Yeah, exactly. The posterior descending artery. Okay. And what arteries supply the anterolateral capillary muscle?
Left circumflex and posterior
Antedescending. Left antedescending. Okay, that's why.
left
And when the
inferior.
capillary muscle rupture occur, you will get the acute mitral. Please remember, you will get the acute mitral regurgitation. We have discussed this case already. You will get the acute mitral regurgitation. You will get a sudden onset of pulmonary edema. Okay, you will get a sudden onset of chest pain, the pulmonary congestion, cough. Okay, you will have a loss of, forward ejection fraction and an increased backward ejection fraction. Okay, so a sudden worsening of the symptoms would be seen. Okay, and a new holosystolic murmur would be present. Okay, so it would be a patient who is lying on the bed, and within 3 days, 5 days of the patient suddenly starting having this chest pain, cough, shortness of the breath, a difficulty breathing. Okay, and the crackle sound in the lungs are seen. Okay, and the new holosystolic murmur would be present. They will ask you the case. It would be the case of acute mitral regurgitation. They can ask you about the ejection fraction. They can ask you about this forward and the backward ejection fraction. Okay. So please remember these scenarios. They can ask you about the change in the contractility, change in the preload, okay, change in the afterload and everything. So be prepared for it. Then after similar time, 3 to 5 days, you can have an intraventricular septal rupture, which is the second most common complication that can lead to the ventricular septal defect. It will be present as the murmur in the tricuspid location, just like the BST murmur. Okay. And yeah, you will also have a risk of arrhythmias. Oh, sorry. That would be all. And for that, you will have an increased oxygen saturation in the right ventricle. Chest pain, a biventricular failure will be there because it's an acute condition, not a chronic condition. Acute symptoms will be there. Chest pain, biventricular heart failure, a new dystonia for that, right? Then comes the ventricular pseudoaneurysm formation. Okay. What can happen? See, when the wall of the MI is ruptured, okay, the wall in which or the area of the heart in which the myocardial infarction occurred, when the wall of that area is ruptured, okay, but the pericardium is adhered, okay, it was normal. So what's going to happen? All the blood will be start leaking out and will be start accumulating inside the pericardium, right? And this can lead to the formation of pseudoaneurysms. Okay, a new thrombus can be formed in that area, right? And it can become dislodged from the area, can become the embolus, can lead to the stroke, can lead to the infarction, systemic infarction. Okay, it will always increase the risk of arrhythmias, like I told you, and the remodeling in the heart can lead to the arrhythmia, right? So this is the ventricular pseudoaneurysm rupture. Now, sometimes what happened because of this free wall, even the pericardium is damaged completely. So a transmural rupture will happen, and that can lead to the leakage out of the blood. Okay, and this can lead to the cardiac tamponade. Very important. This can lead to the cardiac tamponade when the blood is started filling between the two layers of the pericardium. Okay, the parietal and the visceral pericardium. That can lead to the cardiac tamponade, which is the most common cause of death after the myocardial infarction. So if the step one asks you that the most common cause of death within first 24 hours, it would be the ventricular tachycardias. The most common cause of death after 5 days, it would be your ventricular free wall rupture that can lead to the cardiac tamponade. Because of the cardiac tamponade, you have started having heart failure type symptoms. You're having the loss of cardiac output. You're having a very low BP hypotension. Okay, a very high heart rate, and because of that, the patient can die. Okay. Then, because the area where the myocardial infarction occurred, the cells, the myocardial cells from there are lost. Their functions are lost, and that's why because of the loss of function, they cannot contract. So rest of the heart will contract, but not that area, right? And as a result, a true ventricular aneurysm can form. Whenever the heart is contract, because of dyskinesia of that area, you will have the outward bulging of that area, right? So we'll have the true ventricular aneurysm. Okay, and that can further lead to the heart failure. Okay, and this is a very important thing also. whenever they give you a patient with a long history of MI, like 2 months or 3 months, it is a must that after 2 or 3 months, a very high chances are there that after 2 or 3 months, the patient will develop the heart failure. Okay, so you will see that, while doing the U world, that, almost every time whenever they mention the case of heart failure, they will always give you a history of myocardial infarction, a 2 month or a 3 month history of MI. So it is very important thing that can lead to the heart failure, right? The Dressler syndrome is important, which is an autoimmune reaction. See, in case of a post-infarction fibrinous pericarditis, it is due to the neutrophils because of the inflammation. In case of the Dressler syndrome, it is an autoimmune inflammation against the infarcted tissue. Okay, and that can lead to the fibrinous pericarditis. Very important. It is an autoimmune condition, but this post-infarction fibrinous pericarditis is a kind of acute inflammation condition. Both of them have a similar symptoms. They will have a chest pain, okay, the pain in the arms, pain in the shoulder, and the friction rub, the ST segment elevation, but the cause is different. Okay. Then the heart failure will happen ultimately. Okay, it could be due to the infarction. The VST could be there, free wall rupture could be there, capillary muscle rupture could be there with the mitral regurgitation. All of these things can lead to the heart failure. During the acute attack of the MI, because the blood supply to the to these papillary muscles are lost, the dysfunction of the papillary muscles can also happen. See, not the rupture, but the dysfunction in the acute scenario, not after the MI, but during the MI, the dysfunction of the papillary muscles can occur, and that can also lead to the the mitral regurgitation. Okay, so mitral regurgitation can occur during the acute episode of the MI and can happen after the MI. If it happening during the MI, that means it is a dysfunction. And as soon as you do the PCI, as soon as you give the patient drugs, the regurgitation will be resolved. So if the step one gives a history of the patient who is having the MI, and along with the MI, he is having some kind of regurgitation sound. And as you treated the MI, as you do the revascularization, the regurgitation is now resolved. So they will ask you what would be the reason to it. It will be due to the capillary muscle dysfunction, not due to the rupture. If the rupture happened, then you need to do the surgery. Okay, with the drugs, it cannot be resolved. Okay. Okay, so any doubts so far about the complications?
No, thank you.
No.
Okay, then comes the treatment. For the unstable angina, you will do the nitroglycerin, of course. Okay, and similarly, in case of a non-ST segment elevation, you will give the patient angina, you will give the angina therapy like the nitroglycerins. Okay, but in case of the NSTMI, not in the angina, in case of NSTMI, you will give the patient heparin because of thrombosis has already occurred. So there are very high chances that thrombosis can occur in any other part of the body also, right? So anticoagulation therapy with the heparin is must. Okay, you will also give the patient antiplatelet therapy to prevent the further progression of the atherosclerotic plaque or the formation of atherosclerotic plaque in other areas. You will give the patient aspirin or any other NSAIDs, right? You will also give the patient ADP receptor inhibitors, which are same as that of antiplatelet therapy. Two drugs for the antiplatelet therapy. One is the aspirin and second is the clopidogrel, which are the ADP receptor inhibitors. Okay. You will give the patient beta blockers to decrease the heart demand, oxygen demand. Okay. You will give the patient ACE inhibitors sometimes or the okay, in order to prevent the cardiac remodeling, because you know that heart failure is a important complication which is going to happen after the MI. To prevent the heart failure, you will give the patient ACE inhibitors or the beta blockers because they are cardioprotective. You will give the patient statins, and doesn't matter what the cholesterol level of the patient is, whether the patient is having a high cholesterol or the low cholesterol, the statin therapy is must. Okay, very important. And the symptoms would be controlled by the nitroglycerin, and sometimes the pain is controlled by the morphine. Okay, the chest pain in the MI, it is controlled by the morphine. In case of ST segment elevated myocardial infarction, okay, before giving these drugs, you first need to give the patient percutaneous coronary intervention, PCI. Okay, and if the PCI is not available in your hospital, you will give the patient fibrinolysis. Okay, but the fibrinolysis had a complication, which is a cerebral hemorrhage. That's why the PCI is preferred over the fibrinolysis. Okay, only after the revascularization, you will give the patient these drugs. Okay, very important. So any doubt so far for the treatment?
I'm not getting why we are giving anticoagulants for unstable angina. Like the plaque has not ruptured.
See, it is not for the angina, but for the non-ST segment elevated myocardial infarction. It is not for the angina.
No,
Okay.
it's written unstable angina / end
Yeah, I
staining.
know it is written, but we do not give this anticoagulating therapy heparin. We do not give for the unstable angina. I've checked it out on the internet, and I've not seen anything like that. So it is not for the angina. It is for the non-ST segment elevated myocardial infarction. For the angina, the main therapy is a nitroglycerin for a stable one, and for the unstable one, you will try to do, you will give the patient aspirin to prevent the further, increase in this atherosclerotic plaque. You will give the patient aspirin, but not the anticoagulation. That's what I heard from the UWorld and from other sources also. Okay.
Okay.
Heparin is when actually anticoagulation is only given when the thrombosis has occurred. Okay. But this aspirin therapy or the antiplatelet therapy will be given when the atherosclerosis is happening. Okay, so for the unstable angina, you will do the antiplatelet therapy. You will give the patient nitroglycerin, the beta blockers to reduce the heart demands. Okay, and anticoagulation would be given only when the patient is having a myocardial infarction. Okay, that's the important thing.
Okay, I got it. Thank you.
Okay, so we are done with the myocardial infarction, I think. Any more doubt on the previous part?
No.
Okay. Now we studied the cardiomyopathies. We have 3 cardiomyopathies. One is a dilated, one is a hypertrophic, and third is the restrictive. Okay, for the dilated, as the name suggests, a dilation of the heart happen, and like I told you, the eccentric hypertrophy will happen. Okay, the myocardicytes will be added in the series, so that the chamber size would be increased. And because it is pathologic, okay, see, because it is a pathologic, not a physiologic, so it will have a thinning of the wall. Okay, it is the most common type of myopathy. Okay, it could be due to the hereditary condition, which is a mutation in the TTN gene. Very important step one will ask. Okay, if it is hereditary, if multiple family members has a history of dilated cardiomyopathy and the sudden cardiac death, means patient must be having a hereditary condition. It would be due to the TTN gene mutation, which codes for the sarcomere protein the titin. Okay, very important. And if a dysfunction occur, it can lead to dilated cardiomyopathy. Okay. The sporadic conditions includes the alcohol. Remember, the alcohol can cause the vitamin B1 deficiency, and that can cause a dry beriberi. If you guys remember from the vitamin sections.
Yeah.
And that dry beriberi can cause a dilated cardiomyopathy, right? Other drugs include the cocaine. Cocaine can cause the ischemia, okay, infarction, and that can cause a dilation of the heart. Doxorubicin, which is a chemotherapeutic agent, a very important cause of the dilated cardiomyopathy. See, one more drug, one more anti-cancer drug can cause that, and this DCM. If anyone remember the name.
Trastuzumab.
Okay, yeah, very good. Trastuzumab. And what is the difference between the trastuzumab and the doxorubicin? Dilated cardiomyopathy. Both of these drugs can cause a DCM, but what is the difference between the DCM in both of these drugs?
Mechanism of actions are different for both of them.
Of course. But what actually they are doing to the heart?
Not sure about that.
See, in case of a doxorubicin, there will be irreversible damage. It will cause the fibrosis in the heart. And because of that fibrosis and the irreversible damage to the these myocytes, you will have an irreversible damage, right? And that can lead to the this scar formation and dilation. In case of this trastuzumab, it just causes a dysfunction of the myocardium. Okay, and because of a dysfunction, you will have the dilated cardiomyopathy. So if you stop the drug, if you stop the doxorubicin, you cannot have the reverting back of the symptoms. You cannot go back to the original state because the damage is irreversible. But in case of a trastuzumab therapy, the damage is kind of reversible because it's just a mechanical loss. Okay. So if you do the biopsy of the patient, in case of doxorubicin, it will be the fibrosis you will see. In case of trastuzumab, nothing will be seen. Everything would be normal. Okay.
Yeah, okay.
Then comes the infection. Remember the Coxsackie virus, which can cause a myocarditis. Okay, and in the myocarditis, you will have the dilation of all the chambers of the heart, and that can lead to the dilated cardiomyopathy. Okay, Chagas disease. Remember, it can cause the apical uh, thinning of the heart. If anyone remember, apical thinning of the heart would be the Chagas disease, right?
Yes.
So that can cause a dilated cardiomyopathy. And remember the organism for the Chagas disease.
Trypanosoma cruzi.
Exactly. And what does a bruising causes? Trypanosoma bruising.
It
Could you
causes my
Sleeping sickness.
autonomic neuronal loss.
Sleeping sickness. African sleeping sickness.
Yeah, African sleeping
Okay, so
sickness.
remember these things. Then ischemia, of course, when you ever have ischemia, you have a loss of myocyte function that can cause them dilated cardiomyopathy. Okay, some other conditions like hemochromatosis can cause both the restricted cardiomyopathy as well as the dilated cardiomyopathy. In the acute scenario of the hemochromatosis, you can have the dilated cardiomyopathy. In the chronic scenario, you can have the RCM. For the sarcoidosis, you can have both the DCM as well as the RCM. Okay. For the thyrotoxicosis, you can have the DCM. Okay. For the wet beriberi, which can be happened by the alcohol, it can cause the DCM. So these are all the causes of the dilated cardiomyopathy. Okay. Then what are the findings? Findings first would be the heart failure, of course. It would be a systolic or the diastolic heart function dysfunction.
systolic?
Heart cannot be contracted, right? So it would be a heart failure with reduced ejection fraction. Okay. S3 heart sound would be there. Like I told you, if you have an increased heart sound, if you have an increased size of the heart, the S3, which is generated by the sudden, sudden filling of the ventricles when the blood strike against the walls, right? And the walls cannot be stretched further. So you will see the S3 is heart sound. You will cause the regurgitant murmur because of increase in the size. It will cause a regurgitation. You will have the increased size of the heart on the, on the CXR and on the echocardiogram. Okay. And one more thing is the Takotsubo cardiomyopathy, which is known as the broken heart disease. It is seen in the emotional trauma states. Okay, whenever a person lost, his loved ones. Okay, so they will go on in the emotional trauma. So this disease is only seen in the emotional traumas because of the high catecholamine release. Okay, what gonna happen? There will be the apical dysfunction of the heart occur. Okay, all the myocardiosites which are present on the apex of the heart, they will become dysfunction because of this catecholamine synthesis, and that can lead to dysfunction, and that can lead to the apical ballooning of the heart. Okay, very important. That can lead to the apical ballooning, and this is known as the Takotsubo cardiomyopathy. So hypokinesis of the apical segments and the hyperkinesis of the basal segments or other segments of the heart. Okay, we'll have the systolic dysfunction, and that is because of the catecholamine synthesis, which causes the microvascular spasms in the apical area of the heart. Okay, that can lead to the ischemia in the myocardium and the myocardial stenting. Okay, so it must be a patient who has a history of a recent loss of any loved ones. Okay, and mostly they are the old age patients. They will show, and all the ECGs of the patient will show the ST segment elevation. The patient will have a chest pain. Okay, and every symptom of this disease will mimic the myocardial infarction. It would be an old age patient having a chest pain, having a ST segment elevation. Okay, having the diphtheriasis, everything just like the MI. But when you do the angiography, it won't show any lesion. And when the angiography do not show any lesion, and plus the history of the patient with the loss of any loved one, it will lead to a diagnosis of the Takotsubo cardiomyopathy. Very important. What are the treatment? You will, you have to restrict the fluids. You will have to restrict the sodium because with the sodium fluids will come. ACE inhibitors, beta blockers, all the therapies for the heart failure like the ACE, ORPs, beta blockers, okay, anti-aldosterone agents, okay, diuretics, spironolactone therapy, digoxin, heart transplant would be two. Would be done, okay. And what is the cause of sudden cardiac death in case of DCM? Mr. One can ask you.
Arrhythmias.
Exactly, ventricular tachycardias, okay, or the arrhythmias. Then comes the hypertrophic cardiomyopathy. See, 4 things you must remember for the hypertrophic cardiomyopathy. Only the 4 things. Okay. First thing, not the 4, only 3 things, I guess. Okay. First thing is the septal hypertrophy. Very important. And because of the septal hypertrophy, you're going to have a left ventricular outflow tract obstruction. Okay. And because the hypertrophy is there, okay, you will have the ischemia in that area, right? So you will have the angina-like symptoms. Okay. Because of the septal hypertrophy, you're going to have a decrease in the cavity size. Okay. That could lead to a decrease in the preload, and that means a heart failure with normal ejection fraction or the diastolic heart failure. Okay. First thing is the septal hypertrophy, and because of the septal hypertrophy, you're going to have an obstruction in the left ventricular outflow tract. Okay. You're going to have an angina-like symptoms. You're going to have a loss of cavity and a heart failure. First. Second thing are the ventricular arrhythmias, which can cause the sudden cardiac death. Like I told you, any kind of pathological remodeling of the heart can cause the arrhythmias. Okay. Third thing is the systolic anterior motion of the mitral valves. And because of the systolic anterior motion of the mitral valves, you can further have the left ventricular outflow tract obstruction plus the mitral regurgitation. So all of the symptoms are because of 3 things: septal hypertrophy, arrhythmias, and the anterior systolic anterior motion of the mitral valves. For the hypertrophy, you can have obstruction, angina, decreased cavity, decreased preload. For the ventricular arrhythmia, you can have a sudden cardiac death, and whenever you encounter a patient with a hypertrophy, you will have a sudden cardiac death because of the arrhythmias. And the systolic anterior motion of the mitral valves that can cause the left flow outflow tract obstruction and the mitral regurgitation. Okay. Then comes the cause. Cause is the mutation in the myosin binding protein C and the beta myosin heavy chain. Okay, whenever the heart undergo a hypertrophy, it will lead to it will need to lay down of new sarcomeres, right? And all of the sarcomeres contain the beta myosin heavy chain and the myosin binding protein C. So because of the deposition of this myosin binding protein C and the beta myosin heavy chain, you're going to have this hypertrophic cardiomyopathy. Just give me a second, guys. Yeah. So because whenever you have a hypertrophy, you're going to have a laying down of the myosin binding protein C in the beta myosin heavy chain that can lead to the hypertrophy, right? So because of the obstruction, you're going to have the syncope with the exercise because the cardiac output cannot be increased. Okay, you will have a sudden cardiac death because of the arrhythmias in the young athlete, most commonly a case of an athlete. Okay, very important. And yeah, it is an autosomal dominant disorder. Okay, 60-70% time it is a familial case, and that's why the mutation in the myosin binding protein C and the beta myosin heavy chain, right? You will have a diastolic dysfunction as we have discussed. Okay, you have a concentric hypertrophy, often the septal predominance. See, in case of a normal hypertension, you're still going to have a hypertrophic cardiomyopathy, right? You're going to have a hypertrophy of the heart. So how can you differentiate between the hypertrophic cardiomyopathy and the hypertrophy in the hypertension or the aortic stenosis? How can you differentiate?
We will have concentric hypertrophy of LV only in hypertension, while in hypertrophic obstructive cardiomyopathy, we will have a asymmetrical septal wall
Exactly.
involvement.
Whenever you have an asymmetrical type hypertrophy, it means the hypertrophic cardiomyopathy. Whenever a diffuse hypertrophy, that means the stenosis or might be a case of hypertension, right? When you do the biopsy of the patient on the heart, what you will see is the myofibrillary disarray and the fibrosis. Very important. Normally, all the myofibrils are arranged in kind of a regular fashion in the parallel ways. Parallelly, they will be arranged, right? But in case of this HOCM, what gonna happen? There will be a very dysfunctional type of arrangement of the myocardiocytes. Okay, and plus the fibrosis will be there, right? And yeah, there was systolic anterior motion of the mitral valve so that the outflow tract obstruction can occur that can lead to dyspnea and the syncope. Okay, and whenever you have a loss of heart volume, you can see whenever you have a loss of heart volume, this obstruction would be increased. Okay, whenever you have a loss of heart volume, the obstruction would be increased. And whenever you increase the heart volume, the obstruction could be relieved. Okay, so all the drugs which decreases the preload or increase or decreases the afterload, all of them can worsen the obstruction in HOCM. And the drugs which which increases the preload, okay, or they can decrease which increase the preload, or they increase the afterload, or they decrease the contractility of the heart, ultimately increasing the heart volume, they will relieve the obstruction, and which is the beta blocker or the non-dihydropiridine calcium channel blockers like verapamil. Okay, they will reduce the heart rate, they will reduce the contractility, and as a result, the blood volume inside the heart would be increased, so that the obstruction, because see, the obstruction is actually going to happen between the intraventricular septum and the this mitral valve. Okay, if I drew the diagram, this is my septum, which is kind of very much hypertrophied. This is my left ventricle. This is my right ventricle. Okay, you have the mitral valve here. Okay, and then you have the aortic valve here. Okay, this is the next scenario. Okay, because of the systolic anterior motion of the mitral valves, there would be an obstruction occur between the mitral valve and this hypertrophic intraventricular septum. Okay, in order to relieve the symptoms, in order to relieve the obstruction, you must give patient certain drugs which can increase the blood volume inside the left ventricles, right? So the beta blockers and calcium channel blockers could be given, and other drugs like the like the nitroglycerin, okay, which decreases the preload, or the hydralazine, which decreases the afterload. Okay, the diuretics, which decrease the filling, ultimately the ACE and ARBs. All of these drugs are contraindicated in HOCM. Very important. All of them are contraindicated. Okay. So any doubts so far on the DCM and the HCM?
No.
No.
And remember other cause of diffuse hypertrophy, the chronic hypertension, cardiac ataxia, and the aortic stenosis. Very important. So how will you differentiate between the aortic stenosis and the hypertrophic cardiomyopathy? Because see, obstruction is going to happen between the mitral valve and this intraventricular septum, and they will produce a murmur, a stenotic murmur, right? So murmur would be there both in the aortic stenosis and as well as in case of hypertrophic cardiomyopathy. How will you differentiate between the two then?
Maneuvers.
And what maneuvers you would perform?
Hand grip.
Okay, and in case of hand grip maneuver, both the aortic stenosis murmur and the HOCM murmur would be decreased. So it won't help us. Any other maneuver?
Valsalva.
Okay, what we're going to do with the Valsalva?
I don't remember the findings, but probably one will decrease and the other will increase.
See, you just need to decrease the blood flow through the heart. If you decrease the blood flow through the heart in case of HOCM, in case of HOCM, the obstruction will increase and the murmur will increase. Okay. But in case of the aortic stenosis, because the blood flow is decreased, the murmur will decrease, right? So if you do the inspiration, okay, the murmur of the HOCM will be increased and the murmur of aortic stenosis will be decreased. Similarly, in case of a standing Valsalva, the murmur of HOCM will be increased and the murmur of aortic stenosis would be decreased. Okay.
Yeah, okay.
Can you please repeat it?
All the scenarios which decreases the blood flow through the heart, okay, they will increase the murmur in the HOCM and they will decrease the murmur in the aortic stenosis. Okay. Is it clear? Up to here?
Sorry, actually, your voice is interrupted. I can't hear you properly. Can you please repeat it?
Okay, wait. See, in case, see, whenever the blood flow to the heart is decreased, in case of HOCM, the murmur will increase, like we have discussed, right? Is that okay?
Yes.
Okay, and we have discussed whenever the blood flow through a stenotic valve or a regurgitation valve is increased, the murmur will increase, right? Yes.
Yeah.
Okay. So see, in case of HOCM, if I increase the blood flow, the murmur will decrease. In case of aortic stenosis, if I increase the blood flow, the murmur will increase. So any maneuver which is increasing the blood flow in HOCM, like any maneuver which is decreasing the blood flow through the HOCM, okay, right, like the standing Valsalva or the inspiration, they will decrease the murmur. Sorry, they will increase the murmur in the HOCM, okay, and they will decrease the murmur in the aortic stenosis. Is that okay?
Yes. Yeah.
Okay, then comes the restrictive, also known as the infiltrative. Remember the word infiltrative cardiomyopathy, which means you're going to have an infiltration of other tissues inside the myocardium. Okay, it could be the amyloidosis, it could be the sarcoidosis, it could be the hemochromatosis. Okay, it could be the Loeffler's endocarditis, in which you see the eosinophilia. Okay, it could be the post-radiation fibrosis. See, once you do the radiation, because of the radiation, there could be the generation of the reactive oxygen species, right? And that will damages your DNA, your cells, right? And you will have the irreversible kind of injury, ultimately the fibrosis, right? So fibrosis, Loeffler's endocarditis, which is a inflammation with the eosinophils, okay? And one more disease of the young children, which is only seen in the young children, which is the endocardial fibroelastosis. So whenever you encounter a case of a patient, you're suspecting him the restricted cardiomyopathy, and it is a very young children. So this must be the case of endocardial fibroelastosis. Amyloidosis, sarcoidosis, and hemochromatosis, they all can cause the restrictive or the infiltrative cardiomyopathy. In this case, what actually going to happen? You have a thickening of the myocardium, first thing, and second thing, the stiffening of the myocardium. Okay, first thing is the thickening, and second thing is the stiffening. Okay, now because of the stiffening of the myocardium, your heart now your heart cannot be relaxed properly now. As a result, the diastole of the heart is affected. So you will have the diastolic dysfunction. Okay. And when you do the ECG of the patient, you will see the low voltage, even though you are having a hypertrophy because of the deposition of these tissues over the myocardium. You have a very thickened wall. But even after having a thickened wall, you're having a low voltage ECG. Why? Because these are not a true myocardium. These are some other tissues, right, which do not have any contractile property, like, and especially in case of amyloidosis. Okay, so when you do the echocardiogram, you will see the ventricular thickening very much high. Okay, but you will have a low voltage ECG. Okay, along with that, you're gonna have a biventricular heart failure. Very important. You're gonna have the biventricular heart failure, which means immediately with the restricted cardiomyopathy, you will see the right-sided heart failure with the left-sided heart failure, not the progressive type. See, in case of a normal heart failure, first you have the left-sided heart failure, then you have the right-sided heart failure. Initially, you started having these pulmonary symptoms, and the edema developed very later on, in the disease. But in case of a restricted cardiomyopathy, along with the pulmonary edema, at the same time you're having the edema in the rest of the body. Okay, very important. The biventricular heart failure is important. Okay, and for the Loeffler's endocarditis, you will have the hypereosinophilia. Okay, the infiltration of the eosinophils, very important. Okay, and let's move forward. So in heart conditions, because it is a diastolic failure, not a systolic failure, okay, the myocardium is still present. So you will have a left ejection fraction normal completely. Okay, the volume of the heart is normal, or you can say not dilated. Okay, there would be a restricted filling of the heart. Why? Because of the stiffening of the walls of the heart. Okay, and so that the pressure inside the ventricles would be increased so much that all pressure will be transferred back into the atrias at the same time in both the right and the left heart. So we get the biatrial dilation, the dilation of the right and the left atria. Okay. On the imaging, you will have a normal ventricular size and function, okay, and the biatrial enlargement will be there. Okay. Features, the right-sided heart failure features would be very much present at a very initial disease, right? Like the jugular vein distension, like a small sign would be there, in which when you do the inspiration, you will have a jugular vein distension. Okay. Liver congestion would be there, pulmonary edema would be there. Okay. Rhythm disturbances are also very much common because all these iron which is depositing inside the tissue and other tissues which are depositing inside the heart, they will all cause the disturbances because they're ions, right? They will kind of interfere with the normal signaling, and that can lead to the ventricular tachycardia, that can lead to the sudden cardiac death. The most common cause of sudden cardiac death is the ventricular tachycardia. We have discussed that. Causes, we have discussed the amyloidosis, which is kind of sometimes age-related, sometimes AL type. When you see the AL type amyloidosis,
Multiple myeloma.
multiple
Yes.
myeloma, yes, when you have a IG light chains, right? And when you get the AA type,
Chronic inflammatory states.
exactly, by the SAA. So you will see the pinkish material, a diffuse pink material inside the cardiac walls. So how can you, because see, in case of a myocardial infarction, okay, when you do the histology of the tissue, you will see the pinkish material completely because of the cognitive necrosis, like I told you, will get a diffuse eosinophilia. And similarly, in the case of amyloidosis, you will also get a diffuse eosinophilia, the pinkish material. Then how will you differentiate between the amyloidosis and the coagulative necrosis?
Staining.
H&E staining. H&E staining will be used in both. That's why you have this pinkish material.
Congo.
Congo red staining.
That would be a further step. How can you differentiate within the H&E staining only?
By the site, amyloid is extracellular and
Infarction is kind of extracellular, intercellular both. No.
no
See,
idea.
like I told you, in case of a cognitive necrosis, the boundaries of the cells are intact. That is a key thing. The boundaries of the cell will be seen in case of cognitive necrosis. When you look under the microscope, you will see this kind of a structure that we draw for you.
Yeah, the structure
You
is
see this kind of a structure outside boundaries of the cell, and inside it, everything would be pinkish. Everything would be pink. But in case of amyloidosis, no cell would be there, only the protein, right? So it would be a diffuse eosinophilia like that only. No cell would be seen, no cell boundaries, only a diffuse eosinophilia, okay?
okay. Yeah, got it now.
Do not confuse between the these two. They
Can you
will just,
repeat that?
in case of a cognitive necrosis, you will still have the cells, right? The necrosis is happening inside the cells. And in case of a cognitive necrosis, you will preserve the boundaries of the cell, remember?
Yeah.
But the inside structure is completely eosinophilic, pinkish. But you still can see the boundaries, blocks. In case of amyloidosis, because it is a deposition of proteins, not the cells, you will have a diffuse eosinophilia without any cell boundaries. Okay, so you will have a one area which is complete full of this cardiac tissue. Okay, and one area which is just pink, a diffuse pink. No cell will be seen. Okay. Sometimes they will just give you a histology and they will ask you what is the thing you are seeing, whether it is amyloidosis, whether it is a cognitive necrosis. So do not confuse between the two. Looking at the cells will help it. Yes.
So it says in first aid low voltage ECG.
Yeah.
I'm sorry, I'm not sure what that looks like. What does that mean?
See, when you have a hypertrophy, okay, and when you do the patient ECG in case of a hypertrophy cardiomyopathy, sorry, in case of a normal hypertrophy, okay, what you will see, this is the P wave, okay, and the QRS complex is kind of very much big, like that, okay, then normal, and then again like that big. This is the normal this that ECG of a hypertrophic patient. Okay, the QRS complex becomes so much big, okay, that it may overlapping other leads also. Like say if it is a lead 2 and this is a lead 3, okay, then the QRS complex of these two leads will be overlapping each other. Okay, this much big complexes you will get. But in case of a anti-cystic cardiomyopathy, even though you are having a hypertrophy, thickening of the walls, but what you will see is the very kind of normal QRS complex, not a big one. This is a low voltage.
Okay, thank you.
Okay, and yeah, that's it. Other tissues will be the sarcoidosis, and when you do the histology of the patient with the sarcoidosis, what you will see are the granulomas that will help you identifying the cause of the RCM. In case of hemochromatosis, you will see that the deposition of the brown pigments, and do not confuse it with the senile amyloidosis, because in both scenarios you can have the restricted cardiomyopathy. But in case of hemochromatosis, it will always present itself before the age of 40. So a young patient, hemochromatosis, a old patient, senile amyloidosis. For the post-radiation, you will see the fibrosis, the collagen deposition. For the Loeffler syndrome, you will see the high eosinophil count and the eosinophilia. For the endocardial fibrolastosis, it must be a young children or the infants, not an adult. Okay, so these things will help you identify the cause of the disease. Any doubt?
No.
No.
Okay, so I think we should just wind up for now. Okay.
Okay.
Any doubt, you can ask me.
Thank you.
So much, everyone.
Thank you so much.